Welcome to what Virgie says is the 37th TIBDN Education Day, and I believe that to be true, even though I don't know that to be true. One of the differences in life. So let's start with the critically important stuff first, which are thank yous. So first of all, thank you to all of the sponsors of TIBDN Education Days. We could not do it without them. Please talk to them while they're here, visit their booths outside, say thank you for keeping TIBDN Days open. Bigger thank you to everybody in the audience and everybody online and everybody else who does all the work of TIBDN, right? This is, I know I say this every year, but it's also true every year, which is that mostly I get the credit for TIBDN, but it's not me that does the work. It's everybody that does the work, and it's a really big team, and we are always conscious of how much everybody does to support TIBDN and keep it going. Thank you. Special thank you to our investigators, and Virgie's added a new list today, which is past investigators, which is a sign of age. Mine are TIBDNs, I'm not sure which, of people who have moved on or retired. I'm remembering this time to thank the TIBDN Program Committee, currently Kevin, Rob, Julianne, and Larissa, and thanks to Nisha of the ID program for suggestions about speakers. Please email Virgie if you want to be a member of the program committee. This is your opportunity to get people to talk about what you want them to talk about and to organize TIBDN days differently if you want them organized differently. And it's also, from my perspective, a really nice opportunity to get together with a few people a couple of times between the days and talk about what's new and exciting and what people are doing in work around the city and what people might want to hear. Okay, if you're in the auditorium, please set your phones on silence. We will be nagging you all morning about filling out the evaluation form, but it's important for our speakers, but it's also really important for us. It's our opportunity at TIBDN to do more of the things that work well for you and do less of the things that you want changed. The raffle prize, Virgie and Zoe have a fancy new raffle prize app at the end of the day for auditorium participants, and washrooms, you will remember, are on the east side, which is left, down the window with corridors at the end. Those of you who are on virtually, Zoe and Libna will be monitoring the Q&A to ask questions, so please put your questions for the speakers in the Q&A. And here's the agenda for the morning. Once again, you will notice that I've tried to put too many things in too short a space. But I hope it's a kind of a whirlwind of new and interesting things, starting with Larissa Matukas' NIMBLE project, which I've seen pieces of in the last few months, and which is very cool stuff. And moving on to Dr. Erin Scherer from the University of Iowa, who is part of the NIMBLE collaboration and is going to talk to us about nudging in vaccines. And then switching gears for Antoine Corbeil, who's going to talk about moving to molecular testing for enteric parasites, followed by a break, time to look at the posters, talk to people you haven't seen, and then we're going to move on to Yves Longtin, who some of you may not have met, from McGill, who's working on a project thinking about going waterless in intensive care units to reduce the risk of gram-negative infections. So he's got half an hour to persuade you that this is what we ought to be doing. And he probably will, okay. And then Michael, Kurz, Sue, and Shaqil Peermohamed, who's joining us virtually from Vancouver, going to talk about sustainability and greening in infectious diseases and microbiology. And then the last short presentations will be Julianne Kus updating us on Candida auris, and Conrad Isidorczyk, who I think will be with us virtually because he's not bringing his viruses in to infect all of us, thankfully. And then it'll be lunch. Starting with Larissa doing a NIMBLE approach to antimicrobial stewardship. Larissa is one of the people this morning who does not need an introduction, I don't think, to anybody in the room, but I'll do one anyway. She's an associate prof at U of T and a medical microbiologist who was formerly the head of microbiology at Unity Health, and she's done a whole variety of research work in microbiology, but for the last, what, 7 years, Larissa? She's been working on, she's been working on a project to understand how microbiology labs can enhance antimicrobial stewardship. And she's going to talk about at least the preliminary results of that this morning. Over to you.
Good morning, everyone. Thanks for joining us. It's really great to be here. So I'm going to spend the morning talking about NIMBLE, which is our research group name, which is Nudging in Microbiology Laboratory Evaluation, and what the impact can be or what we can do in order to address and support antimicrobial stewardship. So today I'm going to take you through some basic core concepts around what antimicrobial stewardship actually is, explain what the benefits of such a program are, and then specifically highlight the work that NIMBLE is doing that is really examples of how microbiology can play a significant role in stewardship programs. I do have a couple of conflicts of interest to declare, which are both listed here. And really just going to jump into, I hope everybody in the audience is really quite aware that antimicrobial resistance is really a global public health threat. And this shouldn't be news, hopefully, to anybody in the audience. But I think what might be important to remember are some of the statistics that we need to keep in mind and why we're addressing antimicrobial resistance, because it is this sort of underlying, continuously evolving threat. Back in 2016, which was a while ago now, it doesn't seem so long ago, but it actually is. There was a very sentinel report that was put out by Jim O'Neill that actually started to project what the number of associated deaths that would be attributed to AMR. And it turns out that back in 2016, we were projecting that deaths associated with AMR was actually going to surpass our number one killer, which is cancer, by the year 2050. So 2016 is long ago, but we're already in 2026, and so 2050 really isn't that far away. A few years later, this data was updated by another group that actually wanted to look at, well, what are the actual numbers, because these were sort of projected numbers, so there was a different modeling that was done. And in 2018, so just a couple of years later, the actual numbers that were associated deaths with AMR was already at 5 million, which was only behind stroke, ischemic heart, and cancer was 10 million. So really creeping up in the ranks of attributed deaths associated with AMR. So we really need to do things in order to prevent this from continuing to take on or accelerate based on how we've been functioning to date. And so antimicrobial stewardship programs are really an essential piece, one of many, in order to curtail antimicrobial resistance. So stewardship programs actually are responsible for coordinating interventions that are designed to improve and measure the appropriate use of antibiotic agents. And it's not just about choosing the right drug, but it's also about the dosing, how long you provide that therapy for, and even the route of administration. So instead of giving drugs intravenously, is there an ability to move some of these things to oral agents? So antimicrobial stewardship, the goals, what success would actually look like is that you would reduce the amount of broad spectrum, expensive, and more toxic antimicrobials that are being used. Hopefully this will also then lead to decreasing antimicrobial resistance. One of the side effects of using a lot of broad spectrum antibiotics is increasing C. difficile infections. And so the idea is that if you can curtail the use of antibiotics, you will then also curtail C. difficile infections. And right now, the cornerstone of antimicrobial stewardship programs is to provide audits and feedback to the prescribers to let them know how to better adjust their prescribing. And so the whole idea is that we should actually get to a point where our stewardship program shouldn't exist because everybody knows how to use antibiotics judiciously and therefore don't need audit and feedback anymore. There's a lot of guidelines and recommendations out there on how stewardship programs should actually function. The CDC actually has a really nice documents that outline and guide around different settings and how to introduce antimicrobial stewardship programs. I've listed here the core elements that are associated with a hospital, so inpatient antimicrobial stewardship programs. And you can see it's not just about how you prescribe in the audit feedback component, but there's a whole administrative and accountability piece that goes along with this, including education. I'm just going to zero in on one of the core components of the CDC guidelines that actually suggest how microbiology can participate in antimicrobial stewardship programs. And here they talk about two things. One is selective reporting of antimicrobial susceptibility testing results. And secondly is adding comments to the microbiology report to help providers understand and interpret the results that are actually being produced. IDSA, which is the Infectious Diseases Society of America, also has recommendations on how to introduce and the functioning of antimicrobial stewardship programs. Unfortunately, the weak recommendations is associated with the microbiology interventions, which again is around suggesting using selective and cascade reporting of antibiotics over reporting all the tested antibiotics that are performed in the microbiology lab. CLSI also has recommendations. They suggest that each lab should consider developing selective or cascade reporting rules, that this should be done in consultation with the stewardship team. And there's also more locally, IQMH also has recommendations that labs should incorporate, again, some kind of form of selective antimicrobial testing and reporting. And alluding back to one of the other mandates of a stewardship program is to move away from the route of administration from IV to PO. IQMH has also recommended that when you do report antibiotics, that it should be from at least 2 different classes, and preferably at least one of those is an oral agent. So again, trying to find that synergy between microbiology and stewardship. So it sounds like, there are these sort of guidelines or recommendations that are out there, but there are some challenges in order to be able to introduce selective or cascade reporting in the microbiology lab. And some of that has to do with that you may not be consistent from one lab to another. There'll be quite a bit of variability in reporting between one lab versus another lab, and that might be based on the degree of expertise at that institution or the degree of collaboration between the lab and the stewardship programs. It can be actually very labor intensive upfront to set up what those rules are. What are you going to report? What are you not going to report? What's the order in which you're going to report things? So it takes a lot of thought and it takes a lot of time and commitment and expertise in order to do that. And sometimes it cannot actually be automated. So if you don't have a lab information system that can actually hold all those rules and those cascade rules, it's very difficult to expect the bench technologist to remember all of those cascading rules and to be consistently reporting. There's also additional resources. So if you do have an LIS that can incorporate these rules, the IT support that you need in order to maintain those rules, and if you get upgrades to your IT system, to your lab information system, some of those rules will disappear. Now you have to reprogram them. So there still are some challenges in order to be able to do this even in an automated fashion. If you decide that your cascading rules is just based on cost alone, you may not actually be achieving what you're trying to do. You might still end up with reporting a whole bunch of broad spectrum antibiotics. The other piece is around education. So people who are reading the reports may not understand why an antibiotic is not being reported, and they may actually interpret that as it's not being reported, and therefore it's resistant, and therefore can't use it, and therefore I should use something that's more broad spectrum. So again, you have to be careful on how people are interpreting that. And then one of the other things is that it might be difficult to tailor cascade or selective reporting for each institution if you're part of a larger network, or if you're a consolidated lab reporting to multiple hospitals. It may not be feasible for your LIS to report one way to one hospital and another way to the next that you support. So in order to sort of overcome some of these challenges, the requirements for success really require you to have like a really great collaborative relationship between the stewardship team and your microbiology and other key healthcare providers. It's always better to automate as much as you can. You do need to have some kind of system in place in order to monitor and to change your selective and your selective and cascading rules, because you can imagine over time epidemiology changes, new antibiotics are introduced. All of those need to be incorporated into the cascading rules. And clearly, as I mentioned before, so that you don't have misinterpretation of your results, you really need to continuously provide education to your frontline staff in order to be able to interpret those results. In Ontario, so Public Health Ontario is actually monitoring to see which of these different microbiology strategies are being incorporated into labs across Ontario. And this is sort of older data. So back in 2018, And comparing to how things were going in 2016, I just wanted to highlight here, if you look at the strategy of cascade microbiology susceptibility reporting, certainly in large community and teaching hospitals, the vast majority have already introduced cascade susceptibility reporting, but in smaller institutions, it's still a place or a gap that can be filled. But certainly we've come a long way. So back in 2016, overall, only about half of the institutions were actually had introduced this strategy. But by 2018, almost 80% or just over 80% already had introduced this strategy. So cascade and selective reporting is actually a behavioral nudge. It's called Nudge, which was put out by these behavioral economists, Thaler and Sunstein. And it's based on this concept that you alter the choice architecture so that people's behavior is consistently driven in the direction that you want it to be. But it doesn't eliminate their autonomy and choice. It just means that, exactly as the word says, you're just kind of nudging them and influencing them in the same direction every time. So to sort of understand what the concept of nudge really has is I always give this example of what Cheerios and flies have in common. So if any of you have or had, as I've had, little young boys, and you wanted them and you were toilet training them and you wanted them to make sure that you didn't have to clean up after them a lot, I used to put Cheerios into the toilet bowl, and that would really help them to aim appropriately. And actually, the Schiphol airport in Amsterdam, and historically used to have decals of flies that were placed near the drains of urinals, and they actually measured that it resulted in 80% reduction of spillage on the bathroom floor. So Cheerios and flies actually have something in common. Taking this concept to how does this then apply to microbiology? There's different ways of being able to apply nudging strategies in microbiology. And Kachanov back in 2016 actually nicely created a framework for us to follow. So I already talked about sort of the middle one there, which is default or selective reporting, where you restrict the number of antimicrobials that are being reported. You can change the order of the antibiotics that are being presented, which is sort of that eye level. So you put the preferred antibiotics at the top of the list, as opposed to just the way we all by default now report them alphabetically. And then the third way is framing, which is adding comments to the report, which if you think back to some of the guidance documents, also recommended to add comments to the report that can help interpret those results so that clinicians know what might be the more preferred antibiotic, the duration, or even the route of administration of the antibiotic. So this was a very interesting topic to myself and some colleagues. And back in 2016, we decided that this is really early days of how to understand nudging in microbiology. And we undertook a scoping review, which was really just to look at the breadth and depth of literature that existed around this in microbiology and how can we improve antimicrobial use. So we actually searched the literature and we identified about 1,300 papers, and we included 15 in our analysis. And what we found was that for the most part, people studied selective and framing interventions, and that the outcomes associated with these nudging strategies were actually quite positive. So prescribing antibiotics, or the appropriateness and their utilization seemed to be improved with it. Appropriateness was improved. We actually saw more de-escalation of antibiotics, and it actually was cost effective in one of the studies that we identified. But there was nothing about eye level. So eye level was theoretical. So overall, when we actually did our analysis, nudging was actually associated with more appropriate antibiotic prescribing, and it was much more likely than if you didn't have nudging associated with antimicrobial susceptibility report testing. So we decided that this is a really sort of early days still, and there's still a lot of opportunities for us to learn more and to actually study this more. And the things that we identified was that a lot of these studies were sort of cohort or observational, maybe a before-after study. So we definitely needed more rigorous studies to say, is this something that we can change the IDSA recommendations from a weak recommendation to a strong recommendation? So we needed those more rigorous studies. We also recognized that really selective cascade reporting was really the most studied intervention. And so there's an opportunity to do more studies around the interventions framing or even eye level. And most of these studies, again, were done in inpatient adults. So again, certainly not generalizable to the community or even to pediatrics. So there's opportunities to study it in those populations. And even though we had some patient outcomes, we didn't have a lot of patient outcomes. So we really wanted to understand, are there any harms associated with doing this as well? So lots of opportunities for us to continue this work and to study it. So a few years later, so in 2024, we decided to take a look at the literature again to see what was actually going on. Was there more studies that had been introduced? And we had a very specific question around what is the impact of nudging strategies in the microbiology laboratory and its associated outcomes. So just recently, it was published just last month in Clinical Microbiology and Infection. We have reported the impact of microbiology nudges on antimicrobial use and clinical outcomes. So unlike in 2018 when we did our scoping review, you can see that there's been an exponential growth in the number of studies that are actually have anything to do with nudging. And even out of the almost 29,000 papers that we looked at, 45 were included in our meta-analysis. But again, it was still predominantly in adults and inpatients. And again, the rigor or the quality of the studies, the methodologies that were used still wasn't at like that randomized controlled trial level. 42% were still uncontrolled before-after studies. So still not getting the rigor, but we're starting to get more literature. The vast majority of these studies were actually conducted in North America, with a few spattering from the rest of the world. And the vast majority of these studies were done within the past sort of 5 years. So really this exponential growth of studies looking at nudging strategies and the impact on stewardship. So our results from these 45 studies is that still what predominated was studying the intervention of selective and cascade reporting. There was a growing number of studies that looked specifically at framing. And then what was interesting is in this cohort of studies that now individuals were studying the combination of both selective and framing as a single intervention. So not only are you now restricting the antimicrobials that you're reporting, but adding a comment to the report to help people interpret those. Again, eye level was nowhere to be found in the literature, so it continues to be a theoretical intervention. The clinical outcomes that we identified was that nudging was associated with reduced duration of antimicrobial use. So if you actually were subjected to a nudging strategy, and typically that was either framing or selective reporting, you actually ended up seeing that prescribers actually provided 1.7 fewer days of treatment. Similarly, nudging was associated with improved appropriateness. So if you actually saw a report that had a nudging intervention, so whether that was in combination of framing and selective or framing alone or selective alone, regardless altogether, you were almost 2.5 times more likely to prescribe an appropriate antibiotic than if you did not see a report with a nudging strategy. What was new that we actually added was there any evidence of harm by introducing these types of nudging strategies in microbiology? And what we identified is that there was actually no difference in C. difficile rates between nudging or not nudging. There was no difference in length of stay, and there was no difference in mortality. So this seems to be, if it's a relatively easy intervention, that you could actually improve antimicrobial stewardship without there being any harms associated to patients. So I wanted to sort of take a step back and just show you some of the primary literature that was used to inform this sort of meta-analysis. So baseline reporting, just so that everybody understands, is kind of like what you currently do in the laboratory right now. You may actually provide a shorter list of antimicrobials for specific bug-drug combinations, and it's typically in alphabetical order. But when we talk about selective reporting, it's not just leaving it at 5 or 6 antibiotics. This is really reducing it down to 2 antibiotics that you would report. The framing is you could report your 5 or 6 antibiotics, but you add a comment to the report that says the preferred antibiotic is X. And then the eye level is, well, is there some way of changing the order of your antibiotics if the preferred agents are at the top of the list and the rest of them are reported in alphabetical order? So quite a few years ago now, again, 10 years ago, at St. Joe's Health Center, we decided to try selective reporting. And we were targeting fluoroquinolones specifically because they were being overused. There was a high incidence of C. difficile infections and outbreaks, and we saw a really high resistance rate in our gram-negatives to fluoroquinolones. So we initiated a selective reporting policy that was aimed at reducing the use of fluoroquinolones. And this is the before and after report. I'm not sure if you can even see the difference, But here's ciprofloxacin, which is what we would have reported previously, and this is it eliminated from the report. Okay, so this is one example of selective reporting, but not to the same extent of reducing it to 2 antibiotics. We still have most of them. We just removed ciprofloxacin, and we wanted to understand what that impact was going to be. We weren't actually back then, we were not able to automate this. So this was still dependent on the technologists on the urine bench to remember when you had an E. coli that was pan-susceptible to not report or to hide the ciprofloxacin result. The primary outcomes was to look at fluoroquinolone antimicrobial use, but also other antibiotics as controls, so trimethoprim sulfamethoxazole, nitrofurantoin, and amoxicillin clavulanic acid. And then our secondary outcomes were to actually look at the susceptibility to ciprofloxacin for both E. coli and Pseudomonas aeruginosa. And you can see very clearly that before the introduction of our selective reporting, this dark black line, solid line, is ciprofloxacin use, and you can see that it dramatically decreased when we stopped reporting it. And the other antimicrobials were typically remained the same, so they continue to be reported, they continue to be used around the same rate. But just take a look at this solid gray line down here. So low, 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 and then all of a sudden it seems to have climbed post-intervention. This is actually amoxicillin clavulanic acid. And I'll get to interpreting that in a second. What we also saw was actually this percent susceptibility to E. coli and Pseudomonas was actually impacted as well. So E. coli, you could see that this is percent susceptibility on the y-axis, and you can see that the trend was that it was decreasing, so it was becoming increasingly resistant. And when we stopped reporting ciprofloxacin, it was statistically significant that it actually plateaued. So not that it was returning to more susceptible, but it was actually plateauing, so we weren't seeing the same trend in decline of susceptibility. Pseudomonas was similar. Even though this looks like we are gaining susceptibility, it actually is also a plateau from a statistic perspective. So we felt that this study was really critical in establishing the idea that selective reporting actually does influence prescriber behavior, and that we can actually reduce fluoroquinolone use, and that we can actually reduce resistance. The challenges with this study was that there was a lot of confounders. As already mentioned, it wasn't an automated process. We really could only say that it worked with urine cultures because that's the only place where we studied it. And what happened was, which is one of the concerns typically with selective reporting and restricting the use of antibiotics, is this idea of squeezing the balloon. So you shift from one antibiotic use to another class. So we shifted from ciprofloxacin to amoxicillin clavulanic acid, which may not always be the best outcomes, but at least showed that we could actually reduce fluoroquinolone use and reverse that resistance. Another cohort study that we did is that we looked at different labs in the community to say, okay, if you reported X, what was the likelihood of the prescribers ordering X? And what we showed was that when an antibiotic was shown on a laboratory report, the physician was 3 times more likely to prescribe that antibiotic. Again, if you see it, they will use it. If you don't show it, they won't use it. Okay, very simple. So this is what nudging is all about. I wanted to move on to the other example very quickly to talk about framing. So framing is adding microbiology comments or adding comments to the microbiology report. This was a group out of the States where they typically, when they had respiratory cultures, just like many of us, if it was sort of mixed growth and it just looked like commensal flora, they would typically just write commensal respiratory flora. The IDSA guidelines for pneumonia, though, suggested, especially if you were querying ventilator-associated pneumonia, is that you should empirically start and cover for things like MRSA and Pseudomonas aeruginosa. And what they found was that when they just reported commensal respiratory flora in the ICU, they continued the empiric coverage for MRSA and Pseudomonas, which meant they were using broad-spectrum antibiotics and vancomycin for longer periods of time. So what they decided to do was that they wanted to make it very explicit, so they just changed their comment to include that there really was no Staph aureus, MRSA, or Pseudomonas when they reported commensal respiratory flora. What they found was that empiric therapy was de-escalated, and this was a significant reduction. They noticed specifically for MRSA that vancomycin was reduced, and same thing for Pseudomonas, that the de-escalation was more likely to occur. And even the duration of therapy shortened from 7 days down to 5 days. And all of these were statistically significant. What they also tried to show was what was the harm to patients? And whilst it wasn't statistically significant, there was a trend to eliminating acute kidney injury by reducing the breadth and amount and duration of antibiotics that were being used. So a very simple behavioral nudge in microbiology really helped to increase the opportunity to de-escalate antibiotics. I'm not going to go into, in the interest of time, there's a lot of examples of framing. You can add all sorts of comments to the report in order to be effective. So I really just want to end by sort of bringing it all back and just reminding everybody that the reason why we're doing this is really to address antimicrobial resistance, which is a growing global health threat, that there are guidance documents out there that do recognize the role that microbiology plays in stewardship, and we should be paying more attention to those. And NIMBLE is continuing to do its work to look at what interventions are going to be most effective. So stay tuned in the coming months. We'll probably have some more publications out to really help guide what the next steps are in helping to and helping our stewardship programs along to reduce AMR. So I'll leave it there and open it up for questions. Any questions? Kevin?
I'm already a believer. When you showed an example from your super study where the compensation was towards amoxicillin, but in the example of the susceptibility report, amoxicillin wasn't there.
Yeah.
But was it really not there?
It really wasn't there. And so it's very interesting to see that people would have chosen an antibiotic that they felt was more appropriate when ciprofloxacin wasn't there. I think it's because it's an oral agent, and that's why people moved to it. And I'm not sure why, we didn't do the study to understand, why didn't they just go to amoxicillin, which was reported? And why didn't they feel more comfortable using amoxicillin versus amoxiclav? It's a really great question. I don't know whether we have the answer to that.
It just seems odd because everything that we show is that, if it's on the menu, it gets prescribed.
Yeah.
And there you show an example of an antibiotic that wasn't on the menu, where things were transitioned to that antibiotic. Because we're seeing some trends where amoxiclav is increasingly being reported when amoxicillin is susceptible. And we're seeing increases in amoxicillin use, as one might expect with these kind of selective reporting strategies. Anyway,
It's a great observation. I don't have a good explanation for it. I think, as I said, because it's an oral agent, I think people are just have this knee-jerk reaction to go to what they feel, by default, what they feel comfortable using and prescribing. One other question?
Here, I would say that I was able to work in a laboratory that called Cascades, and then also cater to another hospital that doesn't cascade. And one of the doctors complained, right, when you're given this amount of antibiotics, he feels incapacitated. And also another thing is that the doctor should know the progression of his patients looking at the cascade and non-cascade. My question is,
can you repeat the question for one? So just so everybody can hear the question. So there are places where microbiology labs will actually report cascading to clinicians, and then they will also not cascade to other areas. And the folks who get the cascade or restrictive reporting tend to feel that their autonomy is being challenged. And so I agree with you. That is one of the challenges associated with selective or restrictive type of interventions, whether it is in microbiology or other behavioral interventions. You have to find a way to compensate for it. And I think that's why when you look at the literature that we looked at more recently, that now they're combining selective with framing. So you provide a rationale to why you've restricted the results in order for people to understand why they're not getting the full menu. I'm sorry? They may not. And I think there may be some people who do, and there may be some people who don't. And so you end up having to cater to the lowest common denominator, which might be somebody who actually doesn't know. And so I know that we know, but we don't always know what they know. And I think some of the work that NIMBLE is going to be doing is to actually look at frontline users' perceptions of these different types of nudging strategies. In which ones do they feel more comfortable being subjected to? So there's more research that needs to be done and will be coming out.
Okay,
Time
last
for one more
question.
No, go ahead.
How easy it is to measure the potential harms of nudging people? For example, to remove a quinolone, you could imagine that some people who are prescribed for penicillin would trigger more penicillin allergic reactions, for example. So, and I guess that's probably hard to measure that because more patients have better outcome, meaning heal from their infection, but also don't get the first reaction to the nudging.
Great question. So the question was like, how easy is it to measure the clinical impact or harms associated with nudging? I completely agree with you, Yves. I'm not sure that we will be able to measure the direct impact of what the nudging strategy was on clinical outcomes, but certainly we're going to try to, right? So exactly as you said. So if you're going to introduce a strategy that is specifically going to drive more penicillin use, then certainly you want to understand what the impact is to workflow. Like, do you have to do more beta-lactam allergy testing, or are people actually going to have more allergic reactions to those penicillins? So I think that's part of the study, is to really understand what the true impact is. I think one of the other things is just around workflow as well. So, the example of cascade and selective reporting, it might mean that people are calling the lab more frequently to get more test results. And so what is the disruption to the microbiology lab by incorporating it? What is the disruption to the clinical workflow where now they have to call the lab to get more results? So I think all of those things we haven't really fully looked at. And I think that's part of the implementation science, is to look at what are those outcomes and how can we measure them better. Okay, thank you so much.
Thank you very much. Great start to the morning. We're going to shift over now to somebody that you haven't met before, probably. Dr. Scherer from the University of Iowa. He's an associate professor in internal medicine, but he has a PhD in psychology and postdoctoral training in bioethics and social sciences. And he's part of the NIMBLE team working on the principles behind nudging, but he's also worked with a large number of other people thinking about nudging in healthcare in general, and how we need to use behavioral and social drivers to help improve people's health. And he's going to talk to us today about nudging towards vaccination. Assuming I can get his talk. Dr. Scherer, take it away.
All right. Well, thanks for having me. It's always a good time when I can come to Toronto. I've been here a few times before, but it's nice, especially now that I have collaborators here. So, um, all right. So in terms of disclosures, so some of the research I'll be talking about towards the end of my talk is funded by CDC, and it's also informed by work I did as part of my career development award through NIH, which was unfortunately terminated early because they decided that improving vaccine confidence did not improve public health. So as you can tell, I'm not salty about that at all. But it's all right. So ideally, by the end of this talk, you should be able to kind of be aware of at least about. I'm gonna go a little bit into how nudges work, so getting into kind of more of the theoretical underlying nudges, as well as ways nudges have been used two different ways to improve vaccine outcomes. One is to address vaccination constraints, and the other to improve vaccine confidence. So. One thing I also note is that with 30 minutes, I have enough time to I don't have enough time to go into detail on a lot of stuff, but enough time to get dangerous with these things. But so if you have additional questions, I'm gonna have my email at the end, so just shoot me an email. I'm also happy to share my slides too. So going out there. So all right. So biking, cycling in Iowa is really big. And so I'm gonna have you take a little quiz here, and some of them involve biking. But it'll be easy. I know it's so early, so I know your brains are maybe waking up still. So all right. So which is physically easier, to ride a bike up a hill or down a hill? Down a hill. All right. All right. What about riding a bike on a paved surface versus an unpaved rocky surface? Yeah, paved surface. So, and then finally, if you're looking to buy a book here, would it be easier to grab a book that's towards the bottom of these shelves or on the top of these shelves? Yeah, the bottom. Yeah. So in a similar way that our kind of our physical environments and factors in our physical environments make it easier or harder to do kind of physical activities, in a same way, our informational environments, features of our informational environments make it easier or harder to do certain mental tasks. And this is referred to as choice architecture. And so this is just the kind of the context and the features of the context in which a person makes their decisions and how that might impact them. And one thing to note is that whether you intend to or not, you're always designing choice architecture when you're introducing some sort of decision space. So in the case of antimicrobial prescribing, the decision to list them alphabetically is a choice you're making. And so you're influencing people's choice architecture, whether you intend to or not. So it's important to be cognizant of it when designing things. Now, this probably isn't a surprise to anybody, but we don't have unlimited cognitive resources or time when making decisions. Which is probably a good thing. If I spent all the time in the world I could, picking out the color of pie in the morning, that would be very inefficient use of time. And so because of that, our brains have developed a number of biases, which is a tendency to respond a certain way, as well as heuristics, which are mental shortcuts, as a way to help us make decisions, given that we don't have unlimited cognitive processing power and we have limited time. Additionally, and this is somewhat of an oversimplification, but we also evolved two different ways of thinking. One of them, which is commonly referred to as System 1, is slow, it's effortful, it uses kind of explicit rules. So this is more of our deliberative thinking, which is typically what we think of when we talk about thinking and cognition. On the other hand, we also have what's called System 2. And this system is very fast, it's effortless, and it's very intuition based, and it's usually guided by kind of conditioned responses that we've developed based on experiences over time. And a lot of times these align, but sometimes they can diverge, often in interesting ways where what we think influences our behavior can diverge from what actually influences our behavior that we may not have insight into. And so because of both the development of biases and heuristics, as well as the two different cognitive systems, social and behavioral scientists can then utilize these insights to develop nudges, which can then influence behavior. So what is a nudge? I'm not going to hit this point too hard since Larissa did a good job doing it, but I have the exact same quote that she did, so that helps. So, but I do want to emphasize for those of you who maybe were unfortunately missed Larissa's talk, or maybe you're still waking up, the coffee hasn't kicked in yet. But I do want to emphasize a few things. One is that the nudge should change things in a predictable way. That doesn't mean it has the same effect for everybody, but it's going to have, push people in a predictable pattern overall on a population level. Additionally, and as we noted, it shouldn't, restrict people's autonomy, and it shouldn't change economic incentives. If you paid someone $100 to, do something, that's not a nudge. That's just paying someone more money. And then the additional thing, which also gets into economic incentives, is it should be easy to implement, and then cheap to avoid, which is basically just saying, there should be ways if you don't want to, go in the direction of the nudge, you should be able to kind of decide, pick what option you want to choose. So, all right, so interesting, but how do we apply that to vaccines? So, all right, so I think nudges can be applied to vaccines in kind of two broad ways. I think one is by removing vaccination constraints, which is, things that make it, harder to get vaccinated. And then the other side is ways of increasing vaccine confidence. All right, so focusing on that first point about removing vaccination constraints. So again, these are things that make it harder to get vaccinated, and the most common reasons why people, as well, the public as well as healthcare professionals, report making vaccination. It's hard to always recommend do vaccinations is because either they're not aware that they're eligible for vaccination, sometimes, scheduling an appointment can be difficult either because it's difficult to navigate like a website or to call and try to get worked out, or even just finding time can be a challenge. And then, for healthcare professionals, sometimes they don't always recommend vaccines because, you just don't only have so much time during a visit. And so you maybe want to focus on other things. So what are some things we can do to use nudges to kind of bypass or ameliorate some of these? So one is opt-out scheduling. So opt-out scheduling is rather than waiting for the patient to schedule an appointment and to get vaccinated, essentially what you do is you just set up appointments for patients ahead of time and say, hey, you have an appointment on this date at this time. If you want to cancel it, call us or however, they might get rid of it or, get out of it. And this is in contrast to then opt-in where the patient's responsible. And so to give you some examples of ways this has been used, so in this study, essentially what they did is they sent out, letters, or they did in the one condition, but they either sent them letters saying, here's when your appointment is, you can call and cancel it in the opt-out condition. In the opt-in condition, they said, hey, you should get your flu shot, call us and schedule an appointment, or they didn't send a letter. And here you can see, basically that in the opt-out condition, the vaccination rates were around 27%, whereas around 16 to 17% in the other two conditions, which again still pretty abysmal flu vaccination rates, but it's still a double-digit increase, so which is pretty significant. So, and this works with healthcare professionals as well. So, in this one, they did something similar, and you can see in the opt-in condition, only about 16% got vaccinated, whereas in the opt-out condition, 28%, which again, abysmal rates, but you do get that kind of double-digit increase there. So. Another kind of way you can do this is presumptive recommendations. So a presumptive recommendation, or what's been called the announcement approach, is where the healthcare professional just says, you're due for vaccines A, B, and C today. Do you have any questions before we do that? As opposed to, oh, you're due for these vaccines. Would you like to get vaccinated? And so in both cases, they, preserve the autonomy of the patient to decline it. But in the one, if the presumption or the default is that the healthcare professionals indicating is like vaccination's the default versus kind of making it seem kind of wishy-washy on whether they should get vaccinated or not. Also, I don't have a clock up here, so I'm just gonna get my phone up here so I don't go over time. So, another thing that helps improve vaccination rates is standing orders. So, it sounds like you're a clinician, so you're probably familiar with what standing orders are, but if you're not, essentially it's just instead of waiting to put in the order when you're in the room with the patient, it's just if they're eligible for a vaccination, the order is automatically placed so that whoever can fill it when it comes up. And so this is something that's been recommended by the U.S. Community Preventive Service Task Force, which is a group who recommends how to implement recommendations on preventive services. But here you can see in a recent review they did that they found 35 studies that looked at the impact of standing orders, and you can see that on average, it increased vaccination rates by 24 percentage points, which is huge. So it's probably like the biggest increase I've seen for this type of nudge. And so, and you can see it kind of varies based on different things, but overall, that's a pretty good effect there. And then finally, I think this is the last one for this section, active choice. So in active choice, a lot of times there's an implicit choice, when it comes to with a healthcare professional making a vaccine recommendation where, they may see a patient's eligible, but they may choose to just like not think about it too much or kind of gloss over the fact that they're not going to make a recommendation. With an active choice, you're making that implicit choice explicit. So in these studies, they'll have a pop-up, during the visit that says, your patient's eligible for a flu vaccine. Are you going to recommend they get vaccinated or not recommend they not get vaccinated or not recommend? I guess it would be a different way of phrasing it. So it really makes it explicit what the choice is, and then they have to actively choose one of the two options. So they have to they basically have to commit to not recommending it to make that choice. And in this study done at Penn down in the States, there's one interesting finding here I want to highlight first is that if you look at the timing over time, one of the things they found was that vaccination rates recommended decreased throughout the course of the day, which is interesting. So that's one interesting thing they're trying to address. But here you can see that in the intervention where they put that active choice in front of healthcare professionals, that you see, again, around a 10 or 11 percentage point increase in vaccination rates. And here you can see it's up around 60 for flu vaccines, which is significantly better than the previous ones, but still not where we want to be, at least in the United States, where everyone above 6 months is recommended to get a flu vaccine. So. Oh, I do have one more. So the other one I'll highlight here is implementation intentions. And so this is the idea that by thinking about how you will do something, you're going to be more likely to do it. And so one way of doing this is creating if-then plans. So it might be something like, when I get the notification to get my flu shot, I will schedule an appointment. Even just thinking about that makes it more likely that someone's going to actually act on it. Another example is having people indicate a specific date and time that they'll get vaccinated. And that seems to improve vaccination rates. And so this has been done with flu vaccination as well as Hep B for men who have sex with men. There's been studies looking at it. And basically, just listing the date alone doesn't seem to have an effect. It has to be a date and a time. So that's just something small you can do to maybe like we can do to kind of nudge people in the right direction of then getting vaccinated. The trick with implementation intentions is that it primarily works with people who have higher vaccine confidence, because if they have lower vaccine confidence, their intention is going to be to not get vaccinated. So you might cause them to kind of double down on it. So you got to be kind of careful with this one. So. All right. Now, moving on to part 2 of nudges, improving vaccine confidence. And one of the things I want to highlight is during the COVID pandemic, I started shifting away from using the term vaccine hesitancy and using the term vaccine confidence. And I do that for 2 reasons. One is because just talking about vaccine hesitancy makes the problem of vaccine hesitancy loom larger in people's minds and makes that the focus. And the other, and probably more important reason, is that when we only focus on decreasing vaccine hesitancy, we're only really focused on negating a negative and not actually replacing it with anything that's going to, produce meaningful change. And so that's kind of one of the reasons I started using the term vaccine confidence, because it can kind of communicate, higher, lower, and communicates this, not just focus on the hesitancy. So anyway, and most of these are focused on different ways of framing information to try to shift people. And so my actual, my gateway study into this area of research was actually during grad school. And I hadn't done very much in medical decision making prior to this, but I started a collaboration where I was interested in the role of metaphors and how they might shape the way we think about infectious disease risk. And because work in cognitive psychology has shown that metaphors aren't just like linguistic devices we use that are just like rhetorical flourishes, but they actually produce a causal change in the way we think about the metaphor target, because it activates different things in our heads and different associations. And so as an example, in one of the studies we did in this paper, we either described the flu literally, so as a virus spreading through a city, or we use a certain metaphor. So essentially what we did is we had participants read the exact same scenario, and the only thing we changed was whether we said things like, oh, it's a virus spreading through the city, or it's a beast that's, I can't remember the exact phrase, preying on the city, or an army that's invading the city, or it's a slow growing weed going through this, kind of growing through the city. And so, again, on the x-axis, we have the kind of the 4 different conditions, and then on the y, we'll have reported likelihood of getting the flu vaccine. And here you can see that regardless of which metaphor we used, it increased people's reported likelihood of getting the flu vaccine in the upcoming flu season. And we tried to look at different aspects of, we thought maybe like, with the beast and army, it's a very like aggressive sounding or scary sounding. So that's why we went with the weed one. But even the weed one works. So there's something about just using metaphors that maybe makes people more willing to get vaccinated. And the other thing I'll note, which gets on a point that was brought up about unintended harms of nudges, a lot of the work I do focuses on using survey-based experiments, where basically we can, manipulate different things that we're interested in, and then examine, all potential outcomes from doing that. And one of the reasons I like this is because it gives us red flags if there's something that might be problematic. So instead of just jumping into the clinic and doing something and finding out later, like, whoops, that had this unintended effect, we can kind of get a sense of that ahead of time. And as well as getting us kind of an indication of what might be a more promising strategy. So it's kind of my go-to methodology, and it's super cheap and effective, and gets you really high-powered studies. So I'd strongly encourage you all to think about doing that potentially as a way of kind of testing some of these strategies before you kind of jump in the real life. So, oh my gosh, this is poorly organized. All right, so another way we can nudge people is through the labels we use. And so, if you think about it, there's lots of different ways we refer to, viruses, at least in when we're talking to the public. So one is by with influenza. We did a study in the U.S. as well as 10 other European countries where again, we gave them a short news story about the spread of a new type of flu. And the only thing we manipulated in it between them that was different was the label was how we referred to the flu virus. So in one case, we referred to the surface proteins. And we used fictitious ones because we didn't want people's existing kind of associations to bias them. So we used fictitious ones. But so we referred to the H11N3 influenza, or we referred to the animal reservoir. In this case, we chose a horse, so we called it horse flu. Similar to like bird flu, you hear bird flu and pig flu. And then in another one, sometimes they're referred to by, another country or they sound exotic sounding. So you have things like the Spanish flu and stuff. And so we wanted to get something similar, so we called it Yarroman flu, which is Aboriginal for horse. So yeah, again, they had all the same information except for how we referred to this. And so one of the things we found is that relative to the animal reservoir label, the 2 other conditions increased worry about the disease, which then partially explained the relationship and increase in vaccination intentions. And then this doesn't have to just apply to verbal information, but also can apply to visual information. So we did in the same study, we did a manipulation of whether we use a heat map to indicate risk, a dot map, or what we call the picto trend line here. And essentially the heat maps performed good. And part of it was, the dot maps are frequently used to communicate risk, and we just thought they were bad at providing the information people need, and that's kind of what our study found. So use heat maps to indicate risk is the gist of this. So all right, and then I'm going to very briefly touch on some research I'm currently doing, and this is part of work I'm doing. I'm one of the co-PIs along with Natasha Askelson, who's a professor in public health at Iowa. And it's part of this RISE network that CDC is trying to stand up. It stands for Advancing Research and Immunization Services. And the idea is that by funding these thematic research networks, it's going to create more interaction between sites and ideally create kind of synergies and more innovative ideas that can then be used to improve vaccine outcomes. So in the theoretical work underlying this is from a framework I developed known as vaccination is motivated social cognition. And the underlying idea is just that rather than typically focus on addressing misconceptions. And so we think, oh, people are worried about, the vaccine side effects, or they're not worried enough about diseases. And we're focused on these like beliefs that I think are actually kind of epiphenomenal. I think there's underlying psychological motivations. And so I think that these broad categories of psychological motivations that influence whether someone has higher or lower vaccine confidence are sensitivity to and need to manage threats, um, how comfortable they are with uncertainty and their need to kind of reduce uncertainty, having certain social goals, such as, valuing a more egalitarian organized society versus a more hierarchical one, and then information preferences. So whether people prefer scientific information or maybe they prefer intuitions or stories to get their information. And I should note that these are broad categories that can be instantiated in a number of ways. So like threat management could be physical threats, could be symbolic threats, it could be emotional threats. And so there's different ways that these broad categories can be instantiated. And the idea is that people filter their information about vaccines based on where they are on these different motivations. And so this project overall has two steps. One is to look at these different motivational factors and identify which have the strongest kind of absolute statistical association with vaccine outcomes. And then use that to develop what I call motivational fit. And this can be done in two ways. One is to look at the motive that has the largest positive association with vaccine confidence, and then really hammer that home in the messaging. Or you can try to redirect a motive currently producing lower vaccine confidence or vaccine hesitancy. So example of this would be, one of the reasons I think needle phobia, is a barrier for people getting vaccinated is because they're just thinking about the needle stick they get in their arm when they get vaccinated. The way to redirect this potentially would be to highlight the number of needle sticks they'll get if they got hospitalized with a vaccine preventable disease. So that might be one way of kind of redirecting something that currently undermines vaccine confidence and then redirect it in a more positive way. So I'm getting close on time, so I'm going to be very terse on my details. But essentially, what we did is we conducted a survey recently with 3,300 U.S. adults, very demographically diverse sample. We included a number of vaccination measures, so whether they received age-recommended vaccines, as well as some vaccine attitude measures. And we included a crap ton of motivational factor measures. So you can see there's a ton of these measures here. You might be thinking, hey, I don't do survey research, but isn't that a lot of measures? And did your, is this all your respondents did all day? Was they did your survey? And the answer to both is yes. They did it all day. No, I'm just kidding. So essentially what we did to allow us to look at so many measures in one setting and allow them to kind of pit them head to head against each other was by using a planned missingness design. And with this design, you have a set of questions, which are a little block X, where everyone answers those questions. And then you randomly assign the remaining items to a number of other blocks, in this case, 3. So in our study, for each of those motive measures I showed you, there's one that everyone answered, as well as they answered all the vaccination items and the demographics. And then the remaining motive items were then randomly distributed across the 3 blocks. And so what that might look like for needle phobia, for example, is everyone answered this question, I worry about needles when getting a vaccine. And then they would answer, based on which blocks they were assigned to, they'd answer, 2 of these 3 questions. And so for like respondent A, they might answer all the questions in block X and be assigned to answer all the questions in block A and block B, where, respondent B might get, X, A, and C. And the benefits of doing this is because you're randomizing people to the questions they answer, the data is missing at random. And so when you do imputation, then it allows you to do imputation with minimal bias to the estimates, which is normally what you're concerned about. And so I'm just going to quickly show you the results. So I'm just going to, because there's so many measures, I'm not going to show you all of them because that would take like all day. So I'm just going to show you the top 5 motivational factors that we found. So we had a vaccine attitude measure, which went from very negative at 1 to very positive at 7. And we created a composite measure of their vaccination history. So that's the percentage of vaccines they received that were recommended for them. And I just want to highlight here that the top two were the same for both. So emotional reactivity to rare events was the top one. So this is like, if there's a rare event that's going to happen, it's a likelihood that you think it'll happen to you. And then the other one is conspiratorial mindset. So this isn't looking at people's beliefs in specific medical conspiracies or conspiracies. It's the extent to which they endorse the idea that, the kind of official explanation for weird events isn't the actual official explanation. And there's actually these like nefarious groups who are kind of responsible. And so here you can see that both of those undermine, both produce more negative vaccine attitudes and decrease, getting vaccines that you're supposed to receive. And I'll note that while both of those are focused on kind of that threat motivational factor, we see further down a lot of the other ones captured as well. Let's do that. So in conclusion, nudges are strategies that leverage kind of general cognitive intuitive responses to get kind of a desired behavior. Nudges can be used to remove vaccination constraints such as problems scheduling an appointment. And nudges can be used to reframe information in a way that improves vaccine confidence. So with that, again, there's my email address. If you want to contact me, I'll be around all day. So if you want to talk to me, if we don't have too much time for questions, you can talk to me afterwards or in between sessions. So thank you. I realize I threw a lot at you. Way over there.
From an impact event study for recently implemented a strategy where we would email clinicians a list of vaccine is check rates testing one, and then was actually basically returned immediately to baseline. So I'm wondering if you've seen strategies like mentioned strategies that are effective sustainably, as opposed to something that is like exciting and novel, and then everybody is sort of the background.
That is a fantastic question. Yeah. So the question for those of you online was, they implemented a strategy where they gave the healthcare professionals a list of patients who were eligible for vaccination. So had great success the first season, and then after that, it dropped back to baseline. And the question was whether, how can we tell if a nudge is be successful in the long term? Nudges are usually like a one-shot deal, or they're evaluated in a one-shot capacity. And so I think the idea of if you implement, a nudge into something that people have repeated experience with, are you going to see the same effects? And it sounds like, based on your experience, it isn't that case with flu vaccination. You can imagine situations where it might. So I think, antimicrobial prescribing, if you're doing the cascade where you kind of prioritize certain antimicrobials, people will get used to that and then just get used to responding to, at the top. But yeah, that is something definitely worth thinking about is when you introduce any sort of intervention, what are the long-term effects? So that's something that needs to be evaluated more, I think. Oh, one.
How do you think, these types of strategies were for minorities?
Yeah, that's fascinating. Typically, people think that religiosity is negatively associated with vaccine outcomes because there might be religious minorities. I found in my research that religiosity is positively associated with it overall, but you do have different groups who might be opposed to vaccination. And I think part of it is, again, touching on vaccination as motivated social cognition, putting it in terms of their values and belief systems is going to be effective more than just telling them about the disease risk or the benefits of vaccination. I think by highlighting it within language that resonates with them is going to be much more effective than what we currently do. And I think I should note that too, that while I created that vaccination is motivated social cognition for vaccines, I think it could be applied in a broad variety of categories. And since NIH stopped funding vaccine confidence research, I've actually tried to submit proposals to explore it in other contexts. So I'd be happy to chat with people later about how it might apply to your respective areas too. So
Maybe at the top, sorry. maybe after we talk on breathing, we could talk about how we nudge people towards thinking about climate change. And, seeing that magic. Thank you very much, and thank you. So now for something completely different. There we go. You should be set. Antoine Corbeil, again, known to almost everybody in the audience. He's a medical microbiologist at Public Health Ontario who leads parasitology and enteric bacteriology. And he's going to talk to us about switching to molecular testing for enteric parasites, which happened 2 days ago at Sinai, just so we're almost keeping up with PHO.
Yay. Well, thanks, Edison. Hi, everybody. Thanks for joining. So yes, we will shift topics for the next 20 minutes. We'll talk about parasites. Specifically, the parasites that are found in stools. So we'll look at it together. So I'm Antoine. I'm one of the microbiologists working at Public Health Ontario. So I have no conflicts of interest to disclose. So what we'll talk about specifically is the new PCR that Alison mentioned that we've implemented at PHO. And we'll talk about the positive impact that it had, some of the remaining gaps that we'll explore, and some of the future endeavors that we may excitingly look forward together. So we'll try something together. So we'll do a hypothetical scenario together. So if you want to participate, you can take your phone and you can scan the QR code here on the screen, or you can go to slido.com and then input the number on the website. So we'll spend a little bit of time to try to adjust our phones to it. So here's the scenario for us. So let's say that there are 3 healthy household members who develop watery diarrhea on the same day. After a week, the diarrhea is still significant. They have no travel or animal exposures otherwise, and they are vegan and share the same food and water. So the question for all of us is as follows. Which of the following parasites would you test for, if any? So options A, enteric protozoa, option B, enteric helminths or worms, option C, A and B, option D, none, and option E, not sure. So we'll spend a bit of time if we get some responses from the group. So again, testing for protozoa, testing for helminths, testing for both, none of it, or not sure. Sounds like we already have a lot of votes coming in. Seems like a tight race so far. I won't be able to share the results, but maybe we'll leave it up for maybe one more second to see for anyone else who wants to participate. But it looks like we have a large number of votes already. So essentially, it looks like we're kind of neck and neck. It looks like a lot of people say A and B, a third of the participants. But right afterwards, with 25%, we have the enteric protozoa team, and then we have some of the other ones on your options. So this is great because if we were doing this talk a year ago, we wouldn't have that option, at least not at PHO. So a year ago, we would say testing for both enteric protozoa and helminths because that's our package. But now we've changed. So now we're able to really tailor testing based on the clinical presentation. And here, no significant risk factors for helminths. At this point, testing for protozoa would be the recommended approach first. So why protozoa? So protozoa, they're often under-recognized, but they are an important cause of diarrheal illnesses in the country still. Here are some examples of recent outbreaks that happened over the recent years. For instance, we had an outbreak of cyclospora linked to bag salad mixes. There was also outbreaks recently in Alberta related to amoebiasis in a restaurant and cryptosporidium in a petting farm. So we see protozoa often, but as I mentioned, traditionally in the world of parasitology for enteric organisms, we used to provide the full package. So we were testing for protozoa, which are the single-celled parasites. We were testing also for epicomplexans, which are a subgroup of protozoa, and we were testing for the worms, all together into one. But we know that in Canada, the enteric protozoa are common and usually cause acute or subacute diarrheal illness that can persist over time. But then on the opposite side, we have enteric worms, helminths, that are usually more rare in Canada without any risk factors, and usually cause a wide diversity of manifestations. It's also a lot of work for us to test for parasites. So the full package of ONP that you're accustomed to, it's a lot of work for us. So it's hours upon hours of processing time, different steps needed for ultimately looking at it under a microscope. So it takes a lot of effort. And that's probably why we've seen a sharp decline over the past 50 years of the number of labs doing parasite testing in the province. So in the 1970s, we had up to 200 labs doing parasite testing for enterics, and now we're down to essentially 7 labs doing the testing as of last year. What's also hard for labs is not just the complexity of the testing itself, but the expertise needed to identify parasites. So here, that's a list of all the parasites that we can see in stool. It is hard to identify. For some of them, it's a bit easier. For worms specifically, the eggs are bigger, the larvae are bigger as well. So unless you need glasses, you might be able to find some eggs and some larvae on the screen. What might be harder for you, unless you're really at the front row, is to find the protozoa, because the protozoa are really small. So let's zoom in a little bit. So we have the protozoa here in the first row. So the protozoa here, there's a large range still of organisms. These are the single-cell parasites. But a lot of those are non-pathogenic. So a lot of those are actually not clinically relevant. So we have to kind of skim through, find which are the pathogenic ones from the non-pathogenic ones. I'll help you out. So these are the pathogenic ones. So there's 7 main pathogenic protozoa that are found in stool. But to be able to identify those, we have to kind of go through all the other ones, differentiating between them. It's a lot of work. And what we found, at least at PHL, is that more than 90% of our positives that we had over the years by microscopy are these protozoa. So these are the 5 main protozoa that we see in our stools. They represent 90% of our positives. So it's very rare that we actually see the helminths and the other parasites in the stool. So a lot of work, the whole big package of ONP for a limited subset of routine positives. What's great is over the years, there's been development in PCR methods, especially commercial panels that are now able to offer more high throughput, more testing options for these protozoa. So most of the protozoa here now have commercial options. The only one that's a little bit more limited is Cyclospora, where we're still hoping for more and more manufacturers to help design new options for us. But these are available, and for the most part, similar accuracy retrospectively on archive samples. And when we look at prospective samples as well, we see that the overall PCR is more sensitive than microscopy. So I'm sure you've all remembered back in the days, as in the good old days of 2025 and before, is you had to collect like 3 stool samples to improve your sensitivity, because 1 stool sample for ONP, oftentimes the sensitivity was limited. So traditionally, we think of multiple stool samples, but what we see is you can just collect 1 stool sample by PCR, and it's almost identical, if not better, for the most part, for these organisms, as opposed to 3 stool microscopy samples. So that's where we faced this new opportunity for us. So going from the traditional approach to the new approach of offering PCR. But PCR, of course, it's a bit more expensive than microscopy. There's some limitations as well. So we have to be really, really optimal in who needs the test and for which purpose. So here in the new process, we have 2 different streams. So we have the stream of protozoa, which, as I mentioned before, GI illnesses for the most part, or outbreaks. That's when we think of protozoa. And then the helminths. So the helminths, there's a lot more risk factors if you travel, or there's eosinophilia, different food products that you can eat and get exposed to it. So if you have one or the other, you can get one or the other. The one that's in the middle still is the apicomplexans by microscopy. So why are we still offering microscopy for apicomplexans, even though there are some that are part of the PCR panel? So for that, we'll just go back a few slides, all the way here. So going back here, what we can see is those in green, which are the protozoan, the traditional ones, and then those in blue that are the apicomplexans. And there's 2 apicomplexans, Storchocystis and Cystoazospora, that you can see here at the right. Unfortunately, there's no commercial panel still available for them. So either you have to do an LBT, which there's not a lot of research around those, but thankfully they're quite limited in nature. But for those really rare instances, unfortunately, the commercial products, they don't target those at this point. So if we go back to the algorithm that we had before, so apicomplexan microscopy, especially if there's risk factors, then it can be performed upon request as well for some of those. The other challenge as well is that the apicomplexans, they're quite hardy. So they have a big wall, thick wall that is hard to go through. And that's why they're really resilient in the environment. So oftentimes they resist like chlorination and things like that. So it's not until it goes into someone's gut and then gets exposed to all the proteases, all the pH changes, and really the harsh environment in the gut, that they can get released in your gut. And then they release these organisms, which are called sporozoites. So the sporozoites get released from the oocyst, and then and then they go around your gut, and unfortunately, you become infected. So to achieve this, unless you have a gut model in your PCR panel to extract the organism in the gut itself, it's a bit hard to extract the organisms on your own. So as an example here, the US CDC, the way they do it is they do freeze-thaw cycles. So they do like 15 freeze-thaw cycles, bathing in liquid nitrogen, and then heating liquid nitrogen, and so forth. And they say it's really needed to really extract all the organisms to achieve better PCR sensitivity. But then there's other labs that do different things. So there's a lot of variability in what labs are doing. So here another example where a study looked at freeze-thaw, which is what the CDC does, compared to bead beating. And they found that freeze-thaw doesn't really change much, as opposed to even no treatment at all, pre-treatment. Maybe it's because of degradation of DNA, maybe there's other potential causes behind it. But for them, really bead beating was the main option to expand on your sensitivity, for cryptosporidium specifically. So then we looked at it ourselves. So we did some evaluation comparing the different approaches. So we have Perry-Blair, we have unpreserved samples, with or without lysis buffers, and then we have the bead beating approach as well. So for the most part, what we saw is that the lysis buffer helps. And there's a lot of labs currently that are using PCR panels without any treatment at all. And we can see specifically for Candida histolytica, which is the on the right, the second to right, and Cyclospora, we saw some negatives that happened, unfortunately, without any lysis buffer. The lysis buffer helps, so we were able to really achieve successful clinical accuracy with the lysis buffer, but borderline CT values compared to other methods, including bead beating. You can see here in the light blue color. So that's still one of the next frontier for us, is to really enhance PCR performance over time by finding other pre-treatment options. But overall, if we were to look at the performance of PCR in the bigger picture, from a public health standpoint, we saw that when Life Labs implemented a similar PCR in 2017, there was an increase in cases that were diagnosed afterwards. So we know that in practice, we are going to see increase in cases, especially for cryptosporidium, the one in gray here that you can see as well, there was a sharp increase. Of course, there's a decrease in the 2020 onward. I'll let you figure out why there was a decrease in cases. But we can see a same manifestation in other jurisdictions as well. So for example, BC, they also implemented broadly PCR between 2023 and 2024, and we're seeing a sharp increase in crypto detected cases. Same in Denmark, they also did a broad implementation of PCR in their jurisdiction, high PCR positives as compared to microscopy. So let's look at our data. So our data here at PHO, so just looking at our positivity rate, we are also seeing an increase in positivity. Compared to microscopy, really like between 1% and 2% at most, with seasonal spikes in the summer. But when we implemented the PCR, at the same time, there was a large outbreak that we were responding to. But even after the outbreak, we saw PCR positivity was still higher than microscopy. So here, PCR positivity around 3% as opposed to less than 1%. So quite a big shift in the PCR positivity after implementation. Another good positive impact of this is the turnaround time. So PCR, more manageable in terms of high throughput. And you can see here our turnaround times on average. There were some spikes in the summer, again, high volumes, limited staffing. And especially last year, we had a lot of challenges with turnaround times. But as soon as we implemented the PCR, we're seeing a decrease in the turnaround time for microscopy, but also for PCR. So our PCR turnaround time, really drastic difference between what is done by traditional microscopy versus PCR time. So earlier detection of cases, earlier outbreak management, improve outcomes. Another improved outcome of using PCR is that we're now collecting unpreserved or carried blood samples routinely. So traditionally by microscopy, we use a preservative called SAF as the main preservative. But SAF doesn't work well for other testing by PCR for some of the other options we have. So now that we have unpreserved and carried blood samples, we can do more PCR tests for other organisms, bacterial organisms, viral organisms, and so forth. But at the same time, we're able to do more characterization like genotyping, species identification. So that's an example in the US. So in the US, if you recall, I was mentioning a Cyclospora outbreak that happened earlier, linked to bag salad mixes. And what you can see on the right is essentially the genotyping outcomes, predominantly in the US, where they're using more unpreserved samples. And what they found is two colors, the light blue and the orange, so 2020-01 and 2020-03, they were clustering together. And when they went back and questioned the patients that were clustering by genotyping, they were finding a commonality. All the patients ate the same bag product. So that's one way to really enhance tools using unpreserved or carrier samples to really trace from a public health standpoint back to the original source. Okay, so just summarizing the benefits for the protozoa side of things. So from a protozoa standpoint, again, improved sensitivity, improved high yield testing, our positivity rate went up to 3% and more. Reduced turnaround times, essentially by half. Reduced hands-on work per sample from about like 40 minutes per sample down to 1 or 5 minutes per sample at most. Improved daily search capacity, able to take more samples at the same time as opposed to needing more staff to take on a lot of volumes that we're experiencing like in the summer in the surges. Training requirements, so we went from months and months of training down to weeks of training. So really, really more accessible overall. So better outbreak management, better identification as well for Entamoeba histolytica. I didn't mention it, but by microscopy, Entamoeba cannot be distinguished by species. So you need to have the PCR to be able to identify it, and now we have it, so that's great. And as I mentioned, better species identification, and then lower barrier of entry for labs who want to implement protozoa testing, such as potentially here. There's also some downstream positive outcomes, not just for protozoa, but also for worms. So we were talking about the protozoa improving in terms of positivity rate, turnaround times, but worms as well, because as I mentioned, when we implemented the criteria, we were able to really leverage targeted testing to the right individuals for the right reason. And because of that, we saw an increase in positivity rate for worms as well. So these are the helmet microscopy tests, and we can see an increase in positivity rate quite significantly after the implementation of the criteria. And then likewise for the turnaround time, now that we don't do tens of thousands of samples annually to restrict with targeted testing, we're able to really navigate and provide better services for turnaround time for those who need it. So benefits again for the worm side of things, increased positivity rate as well, reduced turnaround time, reduced hands-on work per sample, and then improve expertise for helminths specifically. Instead of knowing all the different non-pathogenic protozoa to try to differentiate between them all the time, now we can focus and enhance our work towards helminth to become even more experts around it. And there's potential solutions in the future to improve detection for helminths. So going back to this picture, there's a lot of worms here. There's more than 50 different types of worms. Unless you have a 50+ PCR panel, it might be hard to identify all of them. And as I mentioned, the epicomplexans, the wall of the oocyst is quite hard, but the eggs are even harder. So we really need that mechanical lysis process. I really like this paper that looked at bead beating for fasciola. So scrambled eggs, a highly sensitive molecular method for fasciola detection. So maybe something in the future we'll do our own scrambled eggs, maybe something to look into. But then another option is to keep microscopy. So microscopy is another option. And then there's a lot of AI tools now that is currently more and more accessible. So there's a list here of options that exist. And because the eggs are better than, or are bigger than the protozoa organisms, the accuracy of AI for helminths is a little bit better than protozoa. Protozoa are small, hard to differentiate between the non-pathogenic and pathogenic ones. So helminth AI detection might be even more accessible. So summarization of what we're doing and what's the next step. So we saw an improvement in testing overall for the enteric parasites. We're going to have to monitor the positivity rate for these organisms, of course, during the summer to try to see if it also impacts public health practices, as we saw early on. We're going to see if PCR adoption is still high in the province. There might still be stragglers who haven't learned about the PCR option yet. So then we'll see better methods to maybe look in the future to expand on cyclospora detection, maybe finding better methods to identify the species or the genotype. And then we'll look at other approaches specifically on unpreserved samples to do microscopy or doing PCR or AI, or maybe we don't even need SCF anymore, because SCF, the main reason around it was for the protozoa, which are quite fragile. The helminths are a bit more hardened. So maybe in the future, we could even consider a world without SCF. So last take-home point for all of us. So as I mentioned, decrease in protozoa and parasite testing overall. But now that testing is more accessible, even the protozoa specifically, maybe you're going to be on them in the future. So we can cheer and celebrate all the achievements in the world of parasitology together. So just acknowledging, Dr. Ninja Bogold and Rachel, who really did a lot of pioneer work. They were ahead of their time and finding a lot of these great ideas. And then Sarah for all of her wonderful work, and then our PHL implementation team. and all the staff that was excellent in navigating all of these exciting changes. And thank you all for your participation as well. So thank you.
Thank you very much, Antoine. A wonderful tour of what the move is, and really nice to see us. It feels like everything got put on hold in the pandemic, and now suddenly there's a chance for microbiology to be moved forward in lots of directions. Comments, questions? George.
Thank you for a very informative presentation. My question, in one of your first slides, there was mentioned that PCRs are more expensive. But then when you continued your presentation, I said 4 times, 2 or 3 times shorter, that's more efficient detection. If you take all these other components in account, I don't think PCR would be more expensive.
That is a good question. So the question was, is PCR truly more expensive, or when you take into account all the other factors, so that includes the time it takes to process the microscopy, the time it takes to read the microscopy, all the different training and all the different other resources needed. Definitely, PCR is actually less expensive than microscopy. So microscopy as a whole package can be quite a resource-intensive process. I agree.
Two quick questions. One is, was it an LDT that you have mentioned, or was it a commercial-based assay? And then secondly, how do you know, or how have you troubleshooted potentially false positives, given the PCR is so much more, you detect it, so much more able to detect parasite?
Great question. So questions are, is it an LDT or a commercial that we went with? And then how do we troubleshoot discrepant results on the PCR as opposed to microscopy? Yeah, so at this point, we use a commercial assay because of our really high volumes. We're really one of the highest volumes in the country. But with the implementation of clinical criteria, we may see a change in volume that will permit to expand the range of testing options with LDTs or other mechanisms. So that's something that we really look forward in the future if we can enhance with our own touch with some of the LDTs available. In terms of discrepant testing, we haven't seen discrepant testing on our clinical evaluation that we did, but we're aware that there could always be issues. We know for the bacterial panels, there was a lot of issues with some of the curves that were misread from some of the bacterial instruments. In the parasite world, we haven't really seen issues with this specific instrument. It's kind of like taking another example, kind of like when we went from electron microscopy to PCR for viruses as well. So when we went from stool EM to PCR, of course, we won't necessarily have the potential to go back to microscopy to really find the organism. In this case, we have the sample, so we can always try to go back to it later on to try to really find any additional discrepancies, but we haven't seen any so far.
Kevin, did I see you? Any other questions? If I know you, but I'm feeling like last week my decision not to go on cruise ships was validated. This week my decision not to buy prepared salads is validated. So is 20-minute break, and then we'll come back to Yves Longtin with his decision about not having sinks in ICUs. Thanks very much. Yeah, no, yeah. Oh, that's what. Start. So we're starting the second half of this morning's program with Yves Longtin. I think Yves is be known to everybody in the audience who does infection prevention and control, and probably everybody in AMI now too, because he's currently the president of AMI. Past president already. That went fast.
For 1 week.
Okay. He's an infectious disease specialist and medical microbiologist at McGill University and at the Jewish General Hospital in Montreal. And he's got a long and broad research career in microbiology, infection prevention and control. And one of the projects he's currently working on is thinking about how to mitigate the risk of gram-negative organisms from water sources in the ICU. He's going to talk to us about whether we should be thinking about going waterless in ICUs.
Thank you, Alex, and good morning, everyone. It's yeah, as presented, the question today that I'm asking or trying to answer or you know advocate or discuss is, are things really necessary in ICUs? Are things doing more harm than good potentially in ICUs? So we're going to go over the literature to present a little bit an overview of the current evidence on the question, identify gaps in the knowledge, and also pitch a potential research project I'm working on right now. Let's see if CRHR likes it or not, which we'll probably know in June or early July. My disclosures, no conflict of interest to disclose with the pharma. I work on different work groups, CNIST and Canada on gram-negative bacteria, but nothing specifically on sinks. My disclosure also immediately is that I'm really new to this topic. I don't work in a hospital that is sinkless. What I have is an interest in infection control and a desire to improve patient care. And also, I know people who work in sinkless hospitals in Europe, and I had the chance to go and visit them. So that's why that's my area of expertise. So if you say it's limited, you are not incorrect. But still, I think I can bring you something today. So let's start with AMR. AMR, as Larissa presented very well, top threats recognized by WHO, Health Canada, the Canadian Health Minister. Very, very important thing to address. Larissa presented already the morbidity and mortality with EMR. One interesting data that needs to be highlighted is how little investment is made to try to combat AMR when we compare to the other great killers infection-wise. So AMR, as per Lancet, it's estimated people spend about $2 billion a year worldwide to combat AMR compared to the 22 billion of HPV or the 3 to 6 billion for malaria and TB. But let's put this into perspective with how many people die of each of these infections, and you see that it's completely paradoxical, or the money doesn't go where really the life savings are. You see that there's underinvestment currently in the fight against AMR if you look at the number of people who die from these infections. So we need to find new ways and invest in ways to combat AMR. Why am I talking about sinks today? Is because this is where the AMR that are most concerning to hospitals right now, especially in ICUs, this is where they live. They live in sink drains. They live in sinks, all the drains, this is where they are. Why am I saying that they're the most important one? Well, if there's this study, for example, here, which is called the Totem study, surveyed ICU specialists, asking them, what are the microbes that are the most worrisome to you? Worrisome meaning difficult to treat, frequent, morbid, costly, etc. And they came up with a top 10. And if you look at the top 10, 8 of them are multi-resistant gram-negative bacteria. This is what the ICU people are worried about. The only 2 missing, MRSA and VR, are the only other 2. 8 of these, so all of these gram-negative are known to be to have a reservoir, which is the sink drains. This is a microbiome study to show you that it is really the case that they live there. For each of these bacteria, Acetobacter, Citrobacter, E. coli, and etc., you have this graph here of their relative prevalence. And when the line is very high on the left side, it means that the source is the patient himself. So the closer you get to the patient himself, the more likely you are to get the bacteria, to find the bacteria in the environment. Whereas if it's on the right side here, this is a water source. So the closer you are to, so here, for example, Rautella, much more prevalent close to the water source. Whereas for Staph aureus, it's more prevalent close to the patient. So you see that most of these gram-negative are more likely to be recovered when you're close to a water source. So why is it that drains are a source of gram-negative bacteria? It's by design. It's a flaw of how plumbing was created. What's the problem with those sewage, those drains, is that there's always the problem of fumes and bad odor coming up from the sewage into up out of the sink drain. So what did plumbers invent to prevent that? It's this P-trap here, which is like a swan neck that is always filled with water.
that prevents the bad odors from coming up the drain. And this is why if you don't use your sink for a while, this will dry up and it will start stinking. So by design, sink drains are made to always have this gray water here, which is full of bacteria and biofilm. As long as it stays there, not there, it's not a risk. But the biofilm falls up about 2 centimeters a day, and are able to reach the sink opening, the drain opening, and from there they can spread. First time I heard about that, I dismissed it. There's a lot of these questions like, it's the floor, the shoes, what about the elevator button? The first time I heard that, maybe 10 years ago, I dismissed it as, this is irrelevant. Sink drain, come on, there's so many other things in the hospital environment. But actually, the literature now is really exploding on this under-recognized potential threat. So how do patients get colonized by the bacteria that hide in this P trap? Because the sinks are being used all the time by the healthcare workers, and because of the splashes as well. Just to illustrate how much splashes can come from the typical sink, there's a very nice observational study that looked at the sink splash zone in an ICU. So you have here a typical ICU, which is cramped, by the way, right? You have the sink here, but you see that the bed is not that far, the computer on wheel is not that far, a lot of material around it. So how far could droplets from the sink travel if you start using it? You think it's like 1 meter, 2 meters away? So very low budget research, but I like it because it shows very well. This is how far they travel. They remove all the equipment in the ICU room. They put some paper on the floor to see droplets fall, and they just activated the sink without even washing their hands. And you see here, they circled all the droplets that fell. So they can travel all the way to 2 meters away from the source. And if you use it, for example, you wash your hands with it, then the droplets are just everywhere. So when it sits within 2 meters, let's go back to the actual picture. Everything is within 2 meters of a sink in an ICU room, if you put a sink in the ICU room, because those rooms are small, right? They're not suites from the Fairmont. They're small. So everything is within splashing distance. So this is the problem. And so they quantify what is the prevalence of the falling equipment within the 2 meter splash zone of the sink? And you see that there's virtually everything within 2 meters. So this is how it gets to colonize the patient. The patient himself also is within 2 meters, of course. And how often are these sinks used? Because if they were never used, you'd be fine, right? The threat would be negative. So what is the use of these sinks? What is the purpose of these sinks? They're supposed to be for hand washing. That's the purpose, officially. But what are they used for? For everything but hand washing. Whenever you need to collect water for, using a little sponge on the patient, wetting the towel, you use it, cleaning the patient after a bowel movement, you're going to go to the sink and wet the towel. These are kind of acceptable uses, but there's also all the unacceptable uses that are done all the time. So nurses will report even washing the urinal after use in the sink before using it again, emptying Jackson Pratts, all these body fluids into the sink drain, emptying nutrition bags, IV bags, antibiotics. There was a study in the UK that found that 50% of sink trap, the P trap in ICUs, contain antimicrobials. They're full of antibiotics because people keep pouring stuff in them. So just to quantify how often the sinks are used and for what purposes, there was this observational study done in the US. And you see that they were used 13 times a day to collect water for care, some crushing medication, flushing it NG2, 10 times a day to empty body fluids and medication into the sink drain. And hand washing was just 3 times a day. So it defeats the purposes completely. They're not used for the correct indication or what they were designed for. So now that we know that they're contaminated, that from there they can contaminate the environment, the next question is this linked with hard outcomes? Are patients really at risk concretely from this contamination? Well, most of the studies so far is mainly observational studies, but they're kind of telling. They add a piece of puzzle to the question. I really like this study here, which is an observational study in 73 ICUs in France. So it's kind of large for an observational study. And what they did is that they looked for the presence of worrisome gram-negative bacteria, pseudo Enterobacteriaceae that are resistant to cephalosporin or carbapenem. So they look at their presence in their drains. They look how dangerous the sinks were, how much splashing they caused, if people had a lot of material around the sinks as well, if they were decontaminating them, for example, with bleach often. So they look at risk factors for the danger represented with the sink, and they look at a potential correlation with bacteremia. So their first finding is that 50% of the sinks were contaminated by MDR bacteria, here, third generation cephalosporin resistant, CPE, or Pseudomonas resistant to imipenem. So 50% were contaminated. If you did not use bleach daily or quaternary ammonium to disinfect your drain, then you are also more likely to have a contamination. But then they came up with risk factors for contamination. And so they came up with 4 risk factors. More than 50% of your sinks are contaminated. Your sinks have a lot of splashes. Your sinks are close to the patient. And you don't clean your sink often. And if you had 3 or 4 of these risk factors, you had a significant higher rate of MDR bloodstream infection in your patients. Very observational. You could say this is post hoc analysis. You know, we did some, you know, if you really go to subgroups, you may find an association. But that's the kind of evidence we have right now, which suggests that there's indeed a risk to patients for having contaminated or dangerous sinks in their room. So could designing better sinks or modify behavior of healthcare workers be a potential solution? There was a very good review article on the topic published by some of your colleagues, Susie Hota and her fellow, Leanne Parks, who's now an ID doc in Montreal. I could refer you to this because it's very comprehensive of everything you can do to make the sinks safer, which is not exactly the purpose of the current presentation. But the only thing I can say is that there's a lot of things you could do. You could disinfect them better. The problem is here, it's very laborious, time-consuming. And for everything that people came up with, I used bleach and it worked. There's virtually another study that said, well, I tried it again also, and it didn't work. So this is very conflicting data. You can also try to make the sink safer or try to encourage people to stop, for example, emptying body fluid into the drains. So making the sink safer, this is the example of a safe sink that you could install nowadays. Much deeper, so the splashes are less likely to spread outside of the sink, with this little splitter at the bottom here, so that when the water hits the bowl, it will cause less splashes. With the drain, which is not aligned with the actual faucet, so there's less splashes as well. This is a safe sink. The problem with these sinks is that they cost $10,000 to $20,000 each to install in an ICU, like retrofitting. They're so expensive to install. That's usually hospitals will be receptive until they see the bill. Not necessarily the cost of the actual sink. It's opening up the wall, the plumbing, etc., and everything has to be hospital grade, right? You cannot go to Home Depot and buy that. So they're really, really expensive. Designing safer sinks, for example, by putting splash guards or making sure there's no material around the sinks that could be contaminated, makes sense. But when you look at it objectively, there's very little you can do given how small those bedrooms are. And then there's technology that's coming up, like using copper pipes instead, or pipes, heating devices, or even ultrasound devices to try to remove and break up the biofilm. But these studies are limited, are mainly studies that look at microbiological efficacy. There's a problem of cost as well, which is an issue. So far, it's an emerging topic, but we're not quite there yet regarding this. Let's see, how am I? Yeah, well, the cheapest method you could do is to use a stop valve. So that's something that's been looked at. The problem is that when you pour some disinfectant, let's say bleach, into your P-trap to disinfect it, the problem is that it flows immediately into the sewage, right? So one thing that people have tried is putting a valve here so that when you put the disinfectant, it stays in contact for at least an hour before opening the valve to try to disinfect it better. This is very low cost, so it's very attractive, right? You just put a stop valve. The problem with these things that, yes, indeed, they are superior to just pouring without the valve in terms of microbial load into the P-trap. It works very well on day 1. But look what happens on day 15, you're back to normal. So even if you have a very effective strategy, here you see 2 weeks later, you're back to baseline. It means that if you go into that direction, you're going to have to do it over and over again, probably every 7 days. So it's going to be, you're going to have to find the labor, the resources to do it, the money to do it. You're going to have to make sure that people are doing it as written in the policy. So you get into the compliance question, which is complex. And you get into this problem that what if someone forgets to reopen the valve afterwards, right? And actually, the architects will tell you bluntly, you can't do that. This is against the building code. You cannot put a valve in a P-trap. You can't do that in Canada. So even if it makes sense from a scientific perspective, you probably won't be able to implement it very easily in your hospital. So sinks associated with increased risk of MDR, bloodstream infection, probably. We have solutions that keep the sinks in, but they probably involve a lot of money, convincing, and behavior change, which we know is very difficult to do. Even hand hygiene, with all the efforts we're doing, we're still at 70% compliance or 80% compliance. You'll never get to 100% by behavior change. So what if we just changed the engineering? What if we just did extreme nudging and removing the sink entirely? And then you get 100% compliance. So that's the idea of banning entirely the sinks in the ICU. Why should we explore this a bit further? First, because it's possible. It's something that may be striking if you've been trained in Canada, that you're working in Canada. Like, how can I, as a nurse or a doctor, care for patients without a sink because I've been used to it? I've never seen the alternative. But many hospitals, or more and more hospitals in Europe, are getting rid of sinks in the ICUs, and it's very doable. You can very well manage patients. Once it's implemented, you got 100% adherence. And the hospitals that have gone sinkless, if you talk to the nurses, to the orderlies there, they say, I'm not going back. I like it the way it is. It's safer. I don't miss a sink anymore. So once it's implemented, it's going to be self-sustainable for the years to come. So how do you make a bedroom sinkless? Well, it's basically replacing the water source, the faucet, by bottled water. We're going to talk about the ecology later. And then when you need to replace draining of biological fluids into the sink, which you're not supposed to do, but you need an alternative, what you use are bags with an absorbent liner in them, and you just empty them in a bag. Let's say a Jackson crack, you put it in a bag with an absorbent liner, and you just throw it and discard of it in the garbage bag. You can clean patients instead of soap and water to wash them. You can use towelettes, those big towels that we're using, they're pre-cleanated. Microbiological studies show that they're as good from a microbiological perspective as washing with soap and water. You have waterless shampoo for patients. Toothbrushing is simply with bottled water as well. So it is very, very doable. You can take all the problems one after the other, or all the nursing aspects one after the other, and you can come up with a waterless, safer solution. It's completely implementable. The first study that looked at the impact of banning sinks entirely, and I think this is going to be a Semmelweis type of study, maybe potentially in 20 years from now, in the sense that it's a study that changed completely our vision of the question, is the Hupman study that was conducted in the Netherlands. It's a before and after study. They only implemented sinkless, and they looked at the colonization of gram-negative bacteria before versus after. And overall, the decrease was mild, from 26 to 21 per 1,000 ICU days, so about a 20% decrease. But what is striking is there's a dose-effect relationship, which really reinforces the finding, in the sense that the benefits were greater for patients who stayed longer. The longer your ICU stay, the greater the magnitude of the decrease in the risk of being colonized. So this dose-effect relationship is a scientific argument to really to establish some form of causality between the intervention. So you see here the drop for patients who remain for 2 days only is not that big. But for patients who remain more than 2 weeks, you see that the drop was much bigger. So here you see the impact. You see the longer your ICU stay, the greater the impact on the risk of becoming colonized by gram-negative bacteria. Other studies have been published since then. Because of time constraint, I'm not going to go over all of them. Instead, going to jump to the systematic review. So there was a systematic review that was published last year. I can go back. Where is it? Here. That looked at what is the current level of evidence on this question. And it identified 7 studies. But one key message is that all these studies were quasi-experimental studies, which means before and after uncontrolled. So this is really a limitation in terms of validity of the findings. 5 of the 7 studies were also implemented in the context of outbreaks. So you have an outbreak, you have to do something, you probably do everything, and get rid of the sink. And we know that what are the threats when you implement an intervention because of an outbreak? Well, there's a lot of potential confounders. You probably did many other things in addition to removing the sink. And also the regression to the mean, which is usually outbreaks will tend to die off eventually. So naturally, you have to be careful before establishing a causal relationship between your intervention. So 5 of the 7 studies were because of outbreaks, which also really limit the conclusions you can draw. But here they are, the 7 studies, and all were positive studies in the sense that they saw a decrease in whatever outcome they were measuring. Was it Pseudomonas, non-fermentative gram-negative bacteria? Was the outbreak, did the outbreak resolve? There's even a study that had to deal with an outbreak of non-tuberculous mycobacteria, and it led to a 80% decrease in the colonization of mycobacteria in that study. So all of them were positive, but you have to take them with a grain of salt. And you don't have also the potential negative studies in the sense that there's no publication bias that was done in that study, in that systematic review. And there was no meta-analysis also, because the studies were deemed to be too heterogeneous. What does our guideline, our Bible in infection control say about sinks? Should we remove them or not? So our Bible in infection control is called the Mayhall. And the only thing they talk about is sink hygiene, having better sinks or making sure that the sinks are used properly. But there's not mention that is done in terms of the need to or potential usefulness of eliminating them entirely from ICUs. Another problem we have with the idea of removing the sinks, because now I'm trying to convince you that it works or that we should do it, is the problem is the CSA, the building standards, the CSA standards. If you read them, they're really explicit that say that every ICU room should have a sink for hand washing. So you're stuck with that CSA standard. So it leads to very, very special situations. For example, in Montreal, there's a big teaching hospital. It's called Maisonneuve-Rosemont that just got close to $1 billion to build a new wing, including a new ICU. And they're trying to build a new ICU without sinks. And they're just being told by the medical architects, you can do that. We need to put sinks in the ICU. This is what the standard is asking. So it's hard to fight against CSA standards. That's the challenge. So what do we know so far about this question? Well, we all agree that multi-drug resistant gram-negative bacteria is an urgent threat to control, that sinks are a well-documented source of gram-negative bacteria, especially a source of outbreaks, and their role in non-epidemic settings is increasingly being recognized. What we don't know is that we don't have good study design so far. What we would need is a real randomized controlled trial that would allow us to establish a real causal effect between the intervention. Even if you do clinicaltrials.gov, there's no similar study. The typical study is people are doing it because of an outbreak. All the barriers to implementing the intervention goes away because of the outbreak. But then you cannot control for all the confounders, doing cost benefit analysis, doing potential harm is not measured. So this is really not the way forward. We don't need another before and after study. If you ask me, why don't you go sinkless in your hospital simply and compare before and after? Because that's being done already, and it's not going to change the standard. The CSA standard are not going to change if we have yet another before and after study. We need to better document also the impact on hard outcomes like nosocomial infections. So that's it. And this is a picture from Geneva University Hospital. This is an ICU room, and this is, you see, a sink where there used to be a sink. It's been covered nicely. They just removed the faucet. This is, you get 100% compliance. It's find another way to clean the patient, but there's no more sink available anymore. So it's completely doable. The site visit was very, very instructive when I went there. So what would be the next logical step? I mean, I can ask you, but I guess you know where I'm going, right? We probably need a formal study that would confirm or infirm the previous findings, determine the cost benefit, the number needed to treat as well, like how good is it? Quantify the potential risk, because that's something that's never reported in the other studies. There are potential risks to going sinkless, right? And you cannot just dismiss them. Could the new washing policy cause more dermatitis? We know that damaged skin is more at risk of causing bacteremias, for example. If we have less hand washing because the sinks are not available anymore, are we going to have more C. difficile, for example, infections, because the alcohol doesn't kill the spores. So we have to also face the truth and look at the problem, even like confronting the potential risks as well. The other consideration we have to take into account is that we're talking about communicable diseases, right? So you cannot do patient-level randomization here, in the sense that if a patient A is colonized by Pseudomonas, the risk that his neighbor becomes colonized is greater than 0, greater than 1, right? So because it's communicable disease, you cannot do randomization at the level of a patient. You need to randomize entire population because there's an ecological effect that is at play here. And the last consideration is when we try to explore the possibility of recruiting entire ICUs to do a study like this, we got a lot of turn down, respectful turn down, in the sense that they didn't know they were able to go sinkless. It's one thing to implement it because you have an outbreak and just try it, we're going to wing it, versus now this is a CIHR study funded, we're going to have to implement it, going to have to be successful, I'm going to have to make sure that the intervention is implemented. So given all this, we thought that the first step would be to step back a little bit and go for a feasibility trial. And this is what we are pitching right now at CIHR. We'll see what they tell us in terms of comments. But the idea of a feasibility trial would be, instead of randomizing entire ICUs, we're going to make small population, recruit 6 ICUs who want to participate. Each of them are probably 30 beds usually. But we're going to ask them to identify 2 clusters of adjacent beds, 6 beds each, that are all in the same area. So once they've identified their 2 little regions, we're going to randomize them to either going sinkless or continuing the standard of care. So that's the idea of a feasibility trial with all the protocol that will be implemented. What we would go for is trying to see if it decreases the risk of acquisition or infection due to gram-negative bacteria of nosocomial importance. And this is a question that is for which there's no clear yes or no answer, but what is going to be the outcome? You cannot use all the E. coli, for example, because everybody is colonized by E. coli. Even Pseudomonas, 25% of people are colonized by Pseudomonas on admission to an ICU, so it probably wouldn't be a relevant outcome. So you need to choose gram-negative bacteria, which is a balance between the likelihood that if you identify them, they're really nosocomially acquired. So you go for CPE, for example, carbapenem resistant, or the steno. That the bacteria is problematic as per consensus, like the totem criteria I presented, and that we're able to detect by culture as well. And this is, I just want to highlight the study that was conducted by many people here in Ontario and Winnipeg, Mike Mulvey, that look at the colonization of Pseudomonas in the sinks in ICUs and the risk of being linked to nosocomial Pseudomonas infection. And it really highlights the fact that in this study, 24% of people were colonized by Pseudomonas overall on admission. And this is a key consideration because these people will be out of the study if they're already colonized on admission, right? They cannot be contaminated. And this is the kind of study that's really useful for us to be able to fine-tune the outcomes of interest. So the idea, I'm going to skip this feasibility trial, the criteria, inclusion, exclusion criteria, but the outcomes of a feasibility trial like this will be to verify, do people really go sinkless? Do people adhere to the intervention? You have here the criteria for feasibility criteria, but also in the control arm. Are people still using the sinks in the control arm? The risk, of course, being that when we start promoting the risk of sinks in the intervention arm, well, people will stop using them also in the control arm. So that's also something that we have to be aware of. And then do people comply with the screening protocol? Because the outcome will most probably include acquisition of gram-negative bacteria during the ICU stay. So you need to screen people on admission and discharge from the ICU to determine an acquisition rate. So you want to make sure that patients are indeed screened as per protocol. And are we able to collect the outcome of interest? And here we have a lot of discussions within the working group. Should we go for infection? Should we go for colonization as an outcome? There are many pros and cons about each of these, but because of the sake of time, we're not going to talk about it this morning. And also to look at the risk of adverse events. And here we enlisted the collaboration of a dermatologist who's a researcher. We'll also look at all the risk of adverse effect, both patient-wise, so the skin breaks and everything, but also healthcare worker-wise. Is there more eczema, dermatitis on their hands in the intervention arm compared to the control arm? So that has been thought at prior. The main outcomes, but this is way too small for you anyway, so you can't read it. The screen is pretty small. But we'll look at the risk of colonization and infection due to gram-negative bacteria. For the screening for colonization, we're going to need to do a rectal swab on admission and discharge, as I explained before. The idea of looking for colonization is because this is much more prevalent than infections, right? So you have more power if you look for colonization. The other thing that is also very interesting with colonization is that you can blind clinicians to it. So if you do swabs on admission and discharge, but you process them only for research purposes and you don't report them to doctors, you will not change the way they prescribe antibiotics, for example. So this is something that will be looked into for a potential study. I'm going to skip the sample size. One thing that people are going to ask us is, yeah, but is it cost, if it were, is it cost effective? And of course, I'm not a health economist, so I will not be able to do a very complex presentation on this topic today. But just back of the envelope calculations suggest it's probably not crazy to think that we could go sinkless. Of course, you're fighting against something that is free, right? The standard of care, water flows freely out of the faucet. The cost is virtually nil. I mean, per patient. Of course, you need plumbers to maintain the equipment and everything, but the cost of the standard of care is virtually zero. So what's the cost of going waterless? Well, you have to go just in terms of consumable, bottled water, the bath, the waterless bath, the hygienic liners to collect the body fluid. You're probably talking about $4 a day, which is not that expensive. I'm not talking to labor here or disposal, but for a 32-bed ICU, you're probably talking about $50,000 a year in consumable, which is not that expensive. Just keep in mind that any patient in the ICU costs $3,000 a day, so this $4 is not that much. And also keep into perspective the risk of not controlling the AMR. Put this into perspective, $50,000 per year for 32-bed ICU to 1 week of cefiderocol to treat a carbapenem-resistant organism, which is $17,000 a week, or the cost of cefalozane tazobactam, which is $40,000 a week. So it is potentially reasonable in terms of cost, that kind of intervention. The other thing that people will ask me, and here I'm fully aware of it, and I think this needs absolutely to be addressed, is what about the ecological? because you're comparing again water flowing from a faucet, which has the water treatment facilities will run regardless of if you ban sinks or not, right? So the cost is probably near zero here, the ecological cost, versus all these single-use and disposable equipment with all the plastic and all this is going to landfill or incinerator. So there will definitely be an ecological impact to the intervention, assuming it works. It means that the cost-benefit analysis will need to take dollar signs into account, but also probably the ecological question. And this is not an answer that that the researcher will be able to answer, but probably society will need to answer. In other words, what will be the social acceptance? How much pollution are you willing to incur to save an infection, for example? And we're already doing it, right, with our single-use syringes and all our protocol for HIV, blood pathogen dissemination. We're already polluting a lot to prevent the spread of infections in hospitals. That will be just another one. And ideally, that's a study we should enlist some experts in all the question of carbon footprint, ecological impact into the study to quantify it, to be able to do a better cost-benefit analysis into that. And just this is the team, I'm presenting today, but I mean, a lot of people are working on that project and maybe more people in the future. Well, thank you for listening. You have questions?
While we're waiting for questions, just to point out that if anybody wants to volunteer thinking about putting their ICU into the study, now would be the time to talk to Yves, because he is going to be looking for candidates. Doesn't get it funded this time. I think he's probably going to get it funded next time. And so the trial is likely to come. Any other questions?
I was wondering for a way to get around that regulatory thing. Maybe there would be to incorporate this stuff in there without removing this thing. And I didn't mention this in my talk, but in addition to nitrogen, there's also called sludges, which can increase friction to make it likely to do something. So if you accommodate the kind of like wireless and even if this thing is still there.
Yeah, you're right. Sorry, maybe I didn't explain myself well enough. For that trial, we would not physically remove the sinks, right? We would just cover them, like the Geneva picture I showed you, without even removing the actual sink. What if it doesn't work, right? I mean, you have to be able to go back if it doesn't work. So we would just cover them. Yeah.
When you visited your places that had actually gone sinkless, what were people's reactions, or how did they learn to live with it? How long did it take them, or like what were some of the repercussions, or what were some of their reactions?
Yeah, it went pretty well. What I have to say though is that it was in the context of an outbreak also, which makes adoption so there's an entire training, you have to write the protocols, you have to train people. So it's not a matter of days, it's a matter of weeks to months to implement. But it's probably a very efficient way of changing behavior, right? Because once it's implemented and these things are covered, people are going to adjust to the new one. And I was surprised to see how much it didn't miss the sinks anymore. Once it's implemented, it runs like it's.
Okay, what's coming next is a tripartite presentation on sustainability. It's going to be shared by Michael Kurz, who's the director of sustainability at the University Health Network, and Sue Poutanen, who everybody knows, and Shaqil Peermohamed, who some of you may remember from when he did his fellowship in Toronto a while ago, who's now in Vancouver and is doing a lot of work with greening of microbiology in Vancouver, and he's going to be presenting virtually. So we'll start with Michael.
Okay, hi everybody. Thanks, Dr. McGill, for the invitation. Always happy to come and share the green word, and happy to be back at Sinai, where both of my kids were born too. So very nice to see everybody, and thank you for the opportunity to talk about these issues. I'll be presenting with Dr. Susan Poutanen and Dr. Shaqil Peermohamed. I'll be talking about general healthcare sustainability. Susan's going to be focused on the sustainability in microbiology labs, and Shaqil is going to talk about sustainability in infectious disease. So first off, what is sustainability? I always like to talk about it as meeting our needs currently without compromising the needs of future generations. At UHN, we do have a long history of treating energy and sustainability with great care, going back to 1999 when the department I lead was founded. And it's culminated in our most recent corporate strategic plan with environmental sustainability codified as one of our foundational pillars. One of the biggest threats in terms of sustainability that we face is climate change, which is the gradual heating of our atmosphere and all the resulting weird and wild things that are ensuing and will ensue. I'm going to try and talk about this in terms of a cause, effect, and cure. So the biggest cause is fossil fuel combustion. That's oil, natural gas, coal, gasoline, and these generate carbon dioxide emissions that cause the planet to heat up. The effects, there's numerous healthcare effects. I would highly recommend checking out the Lancet Countdown, which has a very rigorous scientific breakdown of all the impacts on public health that are ensuing from climate change. Some of the key ones that we face in Canada are an increase to flooding events, higher, more extreme rainfall events that can damage healthcare infrastructure. There is heat-related illness, especially in areas that don't have widespread air conditioning, and that largely greatly affects people that are suffering from homelessness and also mental illness. Some other issues that are commonplace in Canada are air pollution effects of wildfires, and we've seen these all on the increase as a result of climate change. So what's the cure? So I'm in energy management. I like to focus on utilities, emissions, energy efficiency projects. But in reality, the biggest cause of emissions in healthcare is stuff. It's purchasing of medications, supply chain impacts, just generally usage and disposal of healthcare stuff. And our previous presenter highlighted that as well. So thanks for that. And so to give an idea of the scope of our GHG emissions in the healthcare sector in Canada, it's approximately equal to 10 million cars. It's about 5% of the overall emissions of the country. So on Tuesday night, I was listening to a podcast. I know you're thinking, wow, this guy's social life is awesome. He's listening to climate change podcasts in his spare time. But I was on my way to a beer league hockey game. I have friends, I swear. But I basically copied this whole concept from them. And basically, one of the biggest questions that climate leaders are faced with is, how can I help? And this is kind of an awesome thing because it shows most people truly care about environmental sustainability and want to do something about it. So I see this as a blessing. And there's a Venn diagram that I'm copying from this podcast I was listening to. Some of the ways that you can have sustainable climate action. The first thing is figure out what you're good at. So you might be lucky enough to have one sustainability person in your hospital that's focused on that, but I can guarantee they don't know anything about infectious disease. They may know a little bit about IPAC. They're probably not going to know anything about microbiology. So you need to take action in the areas that you know things about. They're going to need your help as a specialist in these areas to tackle the issues. And whether you're good at education, organization, technical analysis, we need your superpower to be dedicated, at least in part, to the solution of this big issue. Then you want to combine that with what needs to be done. And there's so many resources out there, and my co-presenters are going to talk about a few of them. Feel free to reach out to me about any of these, but there's lots of good resources. You can go through them, find out what interests you. And then the last one here is what brings you joy. We're talking about sustainable climate action. If you're kind of banging your head against the wall, it's not filling up your bucket, basically, you're going to start suffering burnout. And that is actually quite a problem in the climate movement, especially the way politics are sometimes. So something that brings you joy, whether it's hugging a tree, typing numbers into an Excel spreadsheet, I don't know, it could be anything, but finding the middle of that Venn diagram is sustainable climate action. So there's a few other concepts that I want to talk about in terms of general sustainability. This is kind of an expanded 3 R's. One of the things I always like to talk about is the only thing worse than single use is no use at all, when we have extra stuff and we just have to throw it out because it's expired or whatever. So the top of the pyramid here is refuse, reduce, and those are the biggest bang for your buck in terms of sustainability. The most expensive is landfill disposal, and then biomedical waste, which often has to be either autoclaved or incinerated, which are highly energy intensive. Another concept that feeds into sustainability is this linear versus circular economy. So most of the economy now follows the linear path: take, make, use, and discard. The idea of the circular economy is to reduce the amount of taking of the environmental resources, minimize the amount of wasting and disposing to the environment, and by reducing, by refurbishing, repairing, recycling, and remaking items, we can reduce the extraction of raw materials and reduce overall environmental impact. Life cycle costing. So whenever you need to buy stuff, the tip of the iceberg there is the purchase cost, and I would say most healthcare procurement is almost entirely focused on that. We've tried to develop at UHN green procurement policies that try to take into account the overall life cycle cost, including all those other impacts below the surface there. A widget up front might be cheaper, but if you have to replace it more regularly, the overall impact and cost could be higher. When we're trying to prioritize the projects that we're working on in the energy and sustainability field, we try to talk about this triple bottom line. Another Venn diagram there is my engineering background. So we try to talk about social sustainability. Is there a tangible benefit for patient, staff, community? Environmental sustainability, are we reducing impact of waste or greenhouse gas emissions? And then financial sustainability, is it saving money and improving the bottom line for the hospital? So the middle of that is sustainability, in my opinion. So we try to add this sustainable procurement guideline to all of our RFPs. And if you guys are buying stuff, you can try to incorporate some of these concepts in that as well. In terms of recycling, some recycling is more valuable than others. Higher value recycling streams include e-waste, batteries, cardboard, scrap metal. We can sometimes actually get money back when these are disposed of properly. Some of the other lower value ones, we generally have to pay to get those recycled because there's no value chain there, essentially. And then I wanted to share a couple of sustainability initiatives that have been successful at UHN. A recent one here is our glove stewardship initiative. This was led by our IPAC department as a way to improve hand hygiene and stop using gloves in place of hand hygiene. And we worked with them on the sustainability aspect of that in terms of reducing waste and also reducing cost. So in 2025, after we started spreading all this information throughout UHN, we've noticed a decrease in glove use of about 13 million gloves, which we're still trying to verify those numbers because it's an insanely high reduction of like 20%, but that's worth about $800,000 of savings, and driven by IPAC, it's in theory improving infection prevention. The other graphic there is from our Shut the Sash program in the wet labs throughout UHN. We have a program where we have all the labs competing against each other to see who can keep their sashes closed when they're not there. And we have a pizza party once a month and educate them about why it's important. Because if the sash is closed, then you don't need to bring as much air into the building. You don't need to heat that air and you don't need to cool that air. So there's a lot of savings associated with that. And then we're all people here. I know we work in a hospital, but we also live somewhere. We get around somehow. So I wanted to say, like, if there's nothing for you at work, you can look at your home life. And some things I did here was getting fossil fuels out of my house. And then also I ride my bike around everywhere. So if you want to support bike lanes, I know some people might love cars, but everyone hates other people's cars, and giving people the option to not use their car is great. So that's another avenue there. So I'll pass it off to Dr. Poutanen now.
Thanks, Michael, and thanks, Allison and team, for inviting me to speak as well. So you'll hear some repeat work in terms of what Michael said, in terms of what we've put together here, and I'll have the next 10 minutes to share with you what we've done. So these are draft choosing wisely statements of sustainability and medical microbiology. It's not just on me in any way. This is on behalf of Deb Yamamura at McMaster, Philippe Lagasse-Viens from Winnipeg, and Larissa Matukas here, who you all know well. We work together to put together these drafts and are just working through with Michael to vet them and then getting them through eventually through MA Canada. So look towards that for those that are MA Canada members. Disclosures, nothing relevant for today though. And objectives will be that you'll be able to list resources. I'm only sharing a few, but you obviously have more with Michael's list there too, about sustainable clinical laboratory use, and to look and describe about these draft ME Canada choosing wisely statements regarding sustainability in MedMicro. So just to give you some resources, there is this wonderful European group, this European Federation for Clinical Chemistry and Laboratory Medicine. It's not specific to micro, but it is specific to clinical laboratories. They have this 2022 guidelines for greening and for green and sustainable clinical laboratories. It's a great document, great resource. If you don't know about it, it's really handy to be able to go through. At the same time, on the right, there is My Green Lab, which you saw as well in Michael's slides there. It has you can see here, a sustainable lab playbook. It has an opportunity for you to actually certify your lab to actually make sure that it is indeed meeting what it can in terms of its greening. And the web links are here, but you can just search for the titles and you'll find them. These two documents were in 2022, and obviously that's when at least it was recognized amongst the MA Canada group. Ultimately, the MA Canada group invited one of the persons who was part of the European group to come and speak. If you were at MA Canada in 2025 last year, they presented, it was Sherry Scott along with Sean Clark, but Sherry Scott was really focusing on the laboratory aspect of, again, greening your lab. And Sean was actually speaking about the impact of climate disease on infectious diseases, but Sherry was speaking about this issue. And then finally, culminating on kind of in getting more information, there was this statement from IPAC, which was in 2025, my understanding, with environmental stewardship, sustainability, and planetary health related to IPAC, a position statement. I'm not going to be reviewing this, and nor will Shaq in detail, but just recognize it's another resource for those that are interested in looking at IPAC-specific green initiatives that your society, the Infection Prevention and Control Canada, put together. But what I'm going to be speaking about is what we did as part of our Healthcare Stewardship Resource Committee. And I mentioned again, Larissa and Deb and Philippe myself, but this is the larger group. Jerome Lease at Sunnybrook is the chair, Shaqil, Philippe Lamb from Sunnybrook, Wayne Gold, who's here from UHN, Sinai, Marie-Félix Granger from Université de Sherbrooke, and myself, Philippe, Deborah, Larissa, and of course, Rick Carter, who's our amazing MA Canada Secretariat, supporting this group. So we've met regularly and we've done different initiatives, but we all focused on looking at what we would do next. And we decided that greening our labs and greening our infectious disease practice was where we wanted to focus. So again, I'll start and then Shaqil will follow with the ID component, and I'm going to be starting with our micro. So we have 6 initiatives. I'll just list them here, and then very quickly, since I only have the 10 minutes, I'll just put some rationale behind them. And then at the end, once Shaq finishes, we'll all be available for Q&A. So the first, in terms of sustainability and micro statement, again, it's not finalized in any way, it's our first draft, is don't use single-use devices in laboratories when reusable, environmentally friendly options are available. And right away, you're probably all thinking loops. And that's like, oh my gosh, we're going to go back to our incinerators and very well, it maybe makes sense to do so. And we're going to have people like Michael actually vet some of these and have these more formalized to look at what might be realistic. But the rationale is indeed single-use plastic. If you think about our loops, when I was getting myself initially trained when I was young, we were not using these plastic loops. We were using our incinerators and using metal loops. So we've all gone to the bags and the loops, and we know how much we go through each day. But think about also our petri dishes. That's quite a lot of plastic. Think about our assay consumables, and some more than others. I mean, some come to mind right away. All this contributes obviously to plastic waste, our microplastic burden in society, and if they need to be incinerated, of course, greenhouse gas pollution as well. Petri dishes, it's estimated, will, in a typical academic lab in a year, will contribute to 16, almost 17,000 kilograms of CO2 emission per year. That's equivalent, I checked it into my Claude Anthropic, was 33 flights from Toronto to Vancouver, back and forth. So a significant from just one individual lab, that has an impact. And so if we can look at alternatives that are more friendly, they don't have to be completely reusable. It may be something that we can look towards. And so Philippe actually put forward this rationale using sustainable or reusable or bioplastic alternatives like bamboo toothpicks for our moldies, like nichrome or platinum inoculation loops going backwards, but nonetheless, and or bioplastic alternatives. So there is a company called Planet Safe looking at bioplastic alternatives for 96 well dishes and for some other plastics that we use, not yet for petri dishes, but may in the future. So really we should be having an eye on these alternatives that we can look towards to try to save on the amount of plastic that we're currently using. In terms of number two, that was number one. Number two is don't leave on laboratory instruments and equipment at the end of the day if they're not being used. Now, if you're a 24/7 lab, may not be relevant, but even if you're 24/7, most don't do everything 24/7. So where can you turn things off? It's amazing when you look through and understand, what we're actually leaving on. Again, labs here, if you look at us compared to an office building, a typical clinical lab is using roughly 3 to 6 times more energy per square meter compared to a typical office building. And keeping all of our equipment on, unused but activated, i.e. on, represents obviously wasted energy and unnecessary greenhouse gas production. So the key would be looking at shutting down our BSCs, shutting down our fume hoods, obviously shutting down our water baths, our heating blocks, which we may have there for convenience or they're ready to go for the morning. Our incinerators, if we're using them, unused incubators, thermocyclers, extractors, et cetera, also turning off the lights, adjusting our heating cooling. We do that at home. Why are we not doing that in our labs? Using sleep mode for your overnight energy savings for your computers, but if it's more than 24 hours, and actually shutting them down in terms of ultimately being efficient in the energy savings of not having to deal with on-offs, et cetera. So that's something that, again, as labs, I don't think we're necessarily focusing on. And yet again, something that we're hoping to really move forward with these initiatives. Number three, don't use lab instruments or equipment that are not energy efficient or that are not routinely maintained. So going on with what you heard from Michael there is look at your instruments when you're dealing with the procurement based on their energy efficiency. We do that again at home. We have all those labels on your dishwashers and the like. And why are we not doing that with our laboratory equipment? So energy efficient equipment that's properly maintained, you pay for that preventative maintenance so that they are being efficient and not wasting energy and not needing more repair than they need to. Yes, will cost up front more, but in the long run, ideally will cost less and will also be more energy sustainable. So we'll use less energy and reduce cost in greenhouse gas emissions. So when you're purchasing, ideally, again, consider energy efficiency, maintain that regular maintenance on your equipment to make sure it's running at its peak efficiency, and your RFPs, your request for proposals, include energy efficiency, packaging, waste, like plastic waste, reusable components as part of what you're considering when you're comparing one instrument and its supplies and consumables to another. Again, something that I don't think we automatically are doing, but it should be more systematically done. Okay, number four, don't discard non-biohazard waste into biohazard waste receptacles. And I know you're all thinking about how many times people wash their hands and put the paper into the convenient discard right near the sink, which may be the biohazard discard, or may not be if your labs are set up properly. But the idea is here is think about what you're putting in which container type. We know that we heard already that we have different processes for different waste in healthcare. Roughly 85% of healthcare waste in general, not labs, is non-hazardous, which means it does not have to be incinerated. It does not need to be autoclaved. We don't want to have that happen if it's not needed. And so putting your hand hygiene tissues into the biohazardous bag may be convenient, but you're wasting the waste that's now going to go and get incineration, et cetera, when it does not need that. So the idea here is your normal lab waste can be put into landfill if it's not hazardous. If it is biohazardous, it would go and be incinerated. And of course, then you've got the byproducts of atmospheric pollutants related to that. And ultimately, if it is chemical, it needs to go into special chemical waste. But again, that's a different type of pathway where you want to make sure only what is needed to go is what's going there. So ensure your waste is sorted appropriately into non-hazardous, biohazardous, and chemical. And make sure you're not cheating and putting things in just because you know it's okay, just because indeed it has a footprint to it in terms of the environment. And reduce your waste quantity as much as you can. Redistribute. If you have surplus, don't throw out. Find other labs if they'd like to have something. Find your research colleagues down the door. If you've bought something in excess, don't just discard because you don't need. And obviously where you can, recycle. And then number 5, don't order unnecessary microbiology tests. Now that's not the lab control, but we are responsible for the pre-analytical. This is our diagnostic stewardship arm. So in his context, easier said than done, but really it really speaks to what we need to be doing as lab stewards and getting out there to work with our clinicians and front-end folks. Roughly, it's estimated 21% of lab testing is estimated to be completely unnecessary. It's 1 in 5 tests. Reducing this obviously will reduce our carbon emissions from reducing our energy and the volume of consumables and waste, et cetera. So really, if you haven't yet had a diagnostic stewardship initiative and started in your hospital, ideally look to starting one. A little different than antimicrobial stewardship, but linked, and you can perhaps have the same teams involved because there is obviously consequences that will also be beneficial to your antibiotic stewardship teams. But the key is reducing that unnecessary repeat testing. Some of that's easy for us because repeats we see. And so we know right now urine CNS, some of us ETT CNS and P swabs we're already rejecting repeats. And also reduce and eliminate the low yield tests like stool CNS OMP from inpatients. A lot of us already are doing that without needing the stewardship teams, but others may need that diagnostic stewardship front-end clinician collaboration. So really look towards what we can do to really remove those low-hanging fruit and then work on the more challenging ones together. And utilize your EMR where possible to really develop interventions that will help to reduce that unnecessary ordering. And then finally, do participate in the My Green Lab certificate program or other similar programs to help reduce your impact on the environment. Missing a word there. And if you don't know about that, I alluded to it at the beginning, but this My Green Lab website includes a certification program that you can run through and see how you're doing with regard to greening your lab. Whether again, that's your micro lab, or if you're responsible for a larger piece of the clinical lab and or your research lab, well worth looking at just to get other ideas of what you could do yourself. So with that, I will just summarize the 2 goals that I'd had to list resources and share the draft Ambient Canada Choosing Wisely statements from our group and pass it over to Shaq, who's online.
Great. Thank you, Susan. So I'm here today to present the draft statements for the Choosing Wisely and Climate Action for Infectious Diseases. Can everyone hear me okay? Okay, perfect. So ID physicians are increasingly confronted with the consequences of a changing planet, highlighting urgent need to integrate planetary health principles into our practice. The AMI Healthcare Resource Stewardship Committee set a task to generate a list of statements as part of the Choosing Wisely and Climate Action Initiative. These statements reflect practical, actionable strategies for ID physicians to align their day-to-day practice with the goals of planetary health. We focused on 4 key domains where change is both possible and impactful: medications, energy use, waste reduction, and travel. By making informed, sustainability conscious choices in these areas, clinicians can help protect both current patients and the broader ecosystems on which future health depends. So our first statement, medications, don't prescribe intravenous antibiotics for patients who can safely be treated with an oral option, given that IV antibiotics have a higher carbon footprint. And I'm not sure if I'm able to advance the slides.
You should be able to just try.
Oh, okay, perfect. So emerging evidence supports the safe use of oral antibiotics for conditions traditionally managed with prolonged IV therapy, including osteomyelitis and infective endocarditis. When clinically appropriate, switching to oral therapy reduces the risk of IV-related complications such as phlebitis, catheter-associated infections, and volume overload, and offers significant patient benefits, including improved mobility, earlier hospital discharge, and better quality of life. From an environmental perspective, IV antibiotic administration requires syringes, tubing, bags, and other single-use plastics, generating more waste and emissions than oral therapy. Our antimicrobial stewardship team in Vancouver recently collaborated with the UBC Clean Energy Research Team, and we published our manuscript in JAMI recently, illustrating how IV administration of highly bioavailable antimicrobials carries 140 times higher carbon footprint than their oral equivalents. So while IV therapy remains essential for certain conditions or when oral absorption is not possible, clinicians should prioritize oral options when safe and effective. Doing so supports antimicrobial stewardship, enhances patient outcomes, reduces healthcare costs, and aligns with efforts to mitigate healthcare's contribution to climate change. Our second statement under the realm of medications: don't pour antibiotics down sinks, toilets, or drains, and don't dispose of antibiotics in the trash. Improper disposal of antibiotics poses serious risks to both human and environmental health. Antibiotics can persist in the environment, promoting the development of antimicrobial resistance. UNESCO has identified antibiotics as emerging pollutants in wastewater due to their widespread ecological impact. Despite these risks, fewer than 1% of patients return unused medications, contributing to pharmaceutical waste. Regulated medication return programs, such as those in BC, offer a safe alternative for disposal and are a critical part of antimicrobial resistance prevention and environmental protection strategies. Clinicians should educate patients on the environmental and health harms of improper disposal and promote take-back programs to ensure that unused or expired antimicrobials are handled responsibly. And we as clinicians can also collaborate with our local waste management and environmental sustainability champions to ensure proper and safe disposal of unused or expired antibiotics. Our third statement, under the realm of medications: don't delay or avoid recommended vaccinations, given immunization prevents disease outbreaks that increase healthcare utilization and environmental impact. Vaccines reduce the incidence of infectious diseases, decreasing hospital admissions, clinical interventions, and intensive resource use that accompany outbreaks. This reduction in disease burden decreases overall healthcare utilization and the associated environmental carbon footprint of medical care, including energy use, medical waste, and greenhouse gas emissions. Climate change is increasing the frequency and geographic range of many infectious diseases, making immunization a key preventative strategy and tool for resilience. Furthermore, vaccines can also prevent disease outbreaks, decrease antibiotic use, preserve microbial diversity, and reduce antimicrobial resistance. Under the domain of waste reduction, we have don't use non-sterile disposable gloves when hand hygiene is sufficient. Gloves are often used unnecessarily during routine healthcare interactions when there is no risk of exposure to blood, body fluids, mucous membranes, or non-intact skin. In these cases, proper hand hygiene provides equal, if not superior, protection against infection transmission. Overuse of gloves can actually increase cross-contamination risk due to reduced compliance with hand hygiene, while also inflating healthcare costs and environmental waste. From a planetary health perspective, disposable gloves contribute significantly to the carbon footprint of healthcare. A UK study found that ICU units used an average of about 107 non-sterile gloves per patient per day, resulting in 2.7 kilograms of carbon dioxide equivalent daily, which is equivalent to driving over 13 kilometers with a gas-powered vehicle. Healthcare professionals should limit glove use to situations where it is clinically indicated or required by infection prevention guidelines. Reducing unnecessary glove use not only supports best practice in infection control, but also aligns with environmental stewardship goals in healthcare. Our second statement under waste reduction: don't print prescription or educational materials when providers and patients have access to digital communication. The routine use of printed materials in healthcare, such as handouts, prescriptions, and clinical guidelines, contributes to paper waste, increased energy use from printing, and unnecessary recycling demands. Transitioning to digital systems reduces environmental impact while improving clinical efficiency and safety. From a planetary health perspective, reducing paper usage supports sustainability by lowering demand for pulp production, conserving water and energy, and reducing greenhouse gas emissions. Even small changes like replacing printed meeting agendas, memos, or patient education materials with digital formats can collectively make a meaningful impact. While printing may still be necessary in some clinical settings, healthcare professionals should adopt a digital-first mindset, choosing electronic alternatives when clinically appropriate. Judicious paper use is a simple yet effective way clinicians can contribute to environmentally sustainable healthcare. Under the realm of travel, we have a statement: don't book in-person appointments when a virtual visit is clinically appropriate. When safe and appropriate virtual care is clinically effective and a patient-centered alternative to in-person visits, particularly for result reviews, follow-ups, and managing stable infectious diseases. Virtual visits reduce exposure risks for vulnerable patients, improve access for those facing mobility or geographic barriers, and support more timely care. Virtual care also has clear environmental benefits. Patient, provider, and staff travel accounts for a substantial share of healthcare-related emissions. In Canada, virtual care helped avoid an estimated 330,000 metric tons of carbon dioxide emissions in 2021 alone. A study in Ontario found that 840 virtual appointments over 6 months avoided over 185,000 kilograms of carbon dioxide equivalent, which is equivalent to more than 750,000 kilometers of travel. And lastly, under the realm of travel, we have don't book multiple specialist appointments on separate day patient visits when these can be coordinated into a single trip or multidisciplinary clinic. Coordinating multiple appointments on the same day where clinically feasible can significantly reduce transportation-related emissions, lower patient burden, and minimize missed work or caregiving responsibilities. Coordination may also reduce duplicative testing and consultation cascades by improving communication between providers. So healthcare systems and clinicians should prioritize collaborative scheduling models and care coordination strategies to streamline patient visits, advancing both sustainability and quality of care. And then our last statement under the realm of energy use: don't routinely perform repeat imaging for intra-abdominal infections, vertebral osteomyelitis, and epidural abscesses post-debridement, given imaging is carbon intensive. Repeat medical imaging, such as follow-up CTs or MRIs for intra-abdominal infections or spinal epidural abscesses post-debridement, should be avoided if results are unlikely to alter treatment decisions. Clinically unnecessary imaging contributes to overdiagnosis, patient anxiety, and incidental findings that may trigger further low-value investigations or interventions. It also has significant environmental implications. Medical imaging is estimated to account for around 1% of global greenhouse gas emissions. So optimizing imaging use improves patient care while contributing to the healthcare system's broader responsibility to reduce its environmental impact. So thanks again for your time today. I want to acknowledge the hard work of the AMI Healthcare Resource Stewardship Committee and guidance from Dr. Jerome Leese and Dr. Wayne Gold. And Michael, Susan, and I are happy to discuss further and answer any questions you have.
Thanks very much. The three of you were a little bit over. I apologize. That's my fault because I gave you like way too much to talk about in way too little time. If there's one or two burning questions, so let me ask a question. I think of all three of you, which is that it felt like I saw a lot of overlap between the mid micro and the ID. Like when you talked about not ordering so many micro tests, I want to say, but that's ID. That's not mid micro. So how do we navigate that?
Yeah, I think it's a great point. I think the thing is, the great question those online that you heard is how do we navigate those overlap? And there is. I think one of the ideas in micro is we have that jurisdiction of the analytical, which is why there's that overlap. But I agree. I think we need to. I will take responsibility for not submitting our micro when we get to Michael. The idea of the need to sit down as a group and look at all of them in compilation, making sure they all make sense and language is similar, and that overlap is minimized as much as possible. There is overlap between what the issues are in general for creating anything. So I think that's going to be not avoidable together. But I do agree that we should make sure that we're comprehensive and capturing everything and not duplicating efforts. I'd be curious, we just asked, anybody actually greened their lab here? From a lab perspective, has anyone heard of greening your lab? Wow, this is a lot of education then. Okay. And how about greening your ID practice? Or IPAC practice? So this is all there's some IPAC practice. Yeah, IPAC is always So and thank you guys. That was from my perspective an awesome presentation and a wonderful set of ideas of how to start moving forward and better on this. Okay. There's only Julianne and me between you and lunch. Candida auris, you knew you were going to have to deal with Candida auris, whether in your lab or your IPAC practice or TIBDN days. So here we are.
Thank you for the invitation to talk about this. I have no conflicts of interest. So I'll just give a little intro to Candida auris, who now has a new name, Candidozyma auris. I will call it Candida auris throughout the presentation because it's still a little controversial in terms of whether this will be adopted. But, you know, with all the phylogenetics and the genomic analyses, it's been determined that it's not really a Candida. So Candida auris was described initially in 2009 from a patient in Japan where it was colonizing the patient's ear, thus the name auris. It was notable because it was multi-drug resistant, and some strains that have been described to date have become pan-resistant, so resistant to all three antifungal drug classes. The other thing that was notable was that it can colonize skin, respiratory tract, urinary tract, and is easily shed from the skin into the environment and contaminating surfaces, especially within healthcare facilities, contaminating surfaces, equipment. And so patients can then become, transmission can occur through direct contact with other patients who are colonized or infected, as well as indirect contact with healthcare settings that are contaminated. So this has been led to lots of healthcare associated infections, high potential for outbreaks in these settings. And the other thing is it is also resistant to many commonly used hospital disinfectants, so our quaternary ammonia-based disinfectants. So all of these things have contributed to it being quite a concern from an IPAC perspective. It's estimated that about 6 to 10% of colonized patients will progress to infection, and the mortality rates from an invasive disease or an infection are about 35 to 45%. So I actually was looking back into my notes and I gave a presentation in 2018 on Candida auris, and this is one of my slides from 2018. So I just wanted to kind of since it's an update, where did we start and where are we now? So then in 2018, the United States had a few sporadic cases. They had about 7 cases between 2013 and 2016. And then as of 2018, there was 215 confirmed cases and 350 colonized patients. There were only a few states that had described having any cases, and some of those that had cases were experiencing outbreaks. And when the investigations into those outbreaks revealed that really only 5 patients who had been hospitalized abroad brought in those Candida auris isolates, and were the resulting cases around there were all linked back to those 5 initial cases. So even though they didn't have that many cases in, oh, I spoiled my slide there. Even though they didn't have that many cases in 2016, the CDC issued a clinical alert to U.S. healthcare facilities on Candida auris, mainly because of the multi-drug resistant aspect. The fact that at that time in 2016, most commonly used yeast identification systems within laboratories were not able to identify Candida auris, or were actually misidentifying it confidently as something else. High transmissibility between patients and environment. Lots of nosocomial infections and outbreaks had been described globally at this point. There was high mortality, and it was really being identified once people were aware of it globally. So 10 years later, the picture looks very different in the United States. This is from the CDC's website. They used to track colonizations as well as infections. A couple of years ago, they abandoned posting those colonizations, and this map and this graph represent just clinical cases. So between 2016 and 2024, there are over 17,000 clinical cases reported and over 35,000 colonizations. And it is now considered endemic in some states. Just in 2024, there were over 6,000 new clinical cases described. And you can see here that during those pandemic years, the cases really did go up quite dramatically. That's attributed to overcrowding in ICUs, IPAC lapses, as well as general chaos that was ensuing within the healthcare system at that time. It's been described that about 90% of Candida auris are resistant to fluconazole, about 30% resistant to amphotericin B. Less than 2%, luckily, have been resistant to echinocandins, but like I mentioned earlier, there have been rare cases where isolates have been resistant to all 3 classes. In 2022, the WHO produced their first fungal priority pathogen list. This was in an effort to draw attention and education, as well as efforts towards trying to tackle these emerging pathogens, and Candida auris was placed into the critical group amongst these fungi. So like I alluded to it earlier, one of the reasons that, or one of the thoughts about why Candida auris was able to spread so rapidly or establish itself so well initially was our inability to confidently identify it, or identify it at all in some cases. So luckily, this is one of the big things that has changed since I presented last time. We have much better methods to identify this organism, and because of that, we have had much better surveillance, and some really excellent surveillance programs now exist within Canada, including the CNIS program, which I won't have time to talk about, but Allison can talk to you about that one day. They've got some really wonderful data, as well as our local, provincial, and national lab-based surveillance programs. So in terms of identification methods, MALDI-TOF, which many labs have now adopted, or most labs have now, it's pretty common. Those current databases for the commercial systems are include Candida auris and are excellent at identifying it. There are now a variety of chromogenic agars that can be used that are specific for Candida auris. There's a variety of different molecular assays that are available, but the caution would still be surrounding those biochemical methods, which are still unreliable. And PHO has, over the years, distributed many Candida auris panels to Ontario labs as well as other provinces to help support validations. So if you haven't got yours yet, please touch base with me and we will be happy to provide that. Kind of general workflows on how one might screen for Candida auris within the lab include collecting a specimen, plating it to chromogenic agar. Any suspicious colonies you can now run on your MALDI-TOF or your other validated identification system. And then the hope would be that you would send those isolates from new cases to PHO for confirmation if needed, but for provincial surveillance and for antifungal susceptibility testing if needed. Additionally, you could use have a screening specimen that would go directly to a molecular detection assay. Any positives, hopefully you might plate those out to grow a culture, and again, follow that pathway of submitting to the provincial lab for provincial surveillance and susceptibility testing if necessary. Obviously, these workflows will vary from lab to lab and depend on a variety of factors. All of the isolates that we receive at Public Health Ontario, we then also forward on to the National Microbiology Lab for national surveillance. So another thing that's changed since in the last very recently is that in January 2025, Candida auris became a disease of public health significance. We can call them reportable or we can call them DOFISes. So this was a big step forward, I think, in terms of trying to collect even more information and data about the spread of this organism in Ontario. So what exactly is reportable? So in Ontario, currently clinical cases or cases in which you have an infection with Candida auris are reportable, or outbreaks. So the outbreaks can be either suspected or confirmed outbreaks. So just prior to Candida auris becoming reportable, PHO collected our lab-based data to kind of see where we were at prior to it becoming a reportable disease within Ontario. So we took all the voluntarily submitted isolates that we received for testing purposes or for surveillance, and I'll present that data here. So between 2014 and 2016, there were 4 unique cases identified within Ontario, here within the GTA. And then between 2017 and 2024, this data is actually available on our website. It's a public-facing report, so you can look at it in more detail later. During that period of time, we had 22 cases of Candida auris identified in Ontario total over that period of time from 20 unique patients. So 12 patient cases were identified via diagnostic testing. So these were clinical specimens that Candida auris was an incidental finding within those samples, and 10 patients were identified through surveillance testing. And unfortunately, 2 of the individuals that were initially identified as colonized went on to then develop infections. And of the 20 patients where we had Candida auris and susceptibility testing, 17 had susceptibility testing, 94% were resistant to fluconazole, 35% resistant to amphotericin, and 0 to echinocandin. So pretty similar to what the Americans are seeing as well. Most patients from our lab-based study were over 60 years old. Most were from Toronto or Peel, although 7 other health units across the province had cases described. I think one of the important findings here was regarding travel and healthcare exposure. So labs would volunteer this information when I would call them and say, hey, you have a Candida auris case. Can you tell me more about this? So thank you to all those people who provided this information. So 65% had recent travel outside of Canada, with 12 receiving medical care abroad, including many from the United States. 6 of 12, so 30%, had no recent travel, and one case we didn't have any data on. 5 of these cases were detected from diagnostic specimens, so not from screening. So since it's become a reportable disease, so we have this 1 year of data now. So from the 2025, I'm sharing here the lab-based surveillance, which we continue to do, as well as the information from IFIS. So those are the ones that are reported. We had 12 cases identified in the lab, 5 from diagnostic testing and 7 through screening. So this is quite a jump from previous years, even though the numbers are still modest. And interestingly, through the official reporting stream, only 2 cases of Candida auris are captured. So you might say, well, 2, how come you have 5? So 3 cases were determined not to be causing infection, but were rather from clinical specimens, but were thought to be only colonizations. So we're not counted through the IFIS system. Toronto and Peel continued to be the most, have the most cases, same age group. Largest risk factors include hospitalization outside of Canada and underlying illness. So what does this look like on the national level? So we, like I mentioned, we forward all of our samples to the NML for national surveillance. So with Dr. Amrita Farhat at the NML, she also receives not just the provincial isolates, but also isolates through CNIS participating hospitals. And this is a summary of cases that she provided me last month or the month before, dating back to 2012 all the way up to just recently. So in Ontario, we've had 43 cases total submitted to the NML, and across Canada, just over 100 cases. So still modest numbers, but you can see that in 2025, we did see quite a substantial uptick. The blue bars represent Ontario and Quebec. The black line represents Ontario. Ontario is contributing quite a number compared to the rest of the country, even though numbers are still quite modest. And this is thought to be due in part to perhaps, yes, there are more cases, but more labs are screening. More labs have the capability of testing and screening and are doing so. So in addition to case counting, the NML also provides whole genome sequencing for all of the isolates that they receive. This, we can determine which geographic clade the organisms come from. It also helps support identification of clusters, which you can't see here because they're so similar at this level. But when you look in more detail at each specific clade, you can see those relationships. And finally, I think this is one of my last slides. PHO, now that we have all this information on Candida auris and risk factors, and we are able to screen and do surveillance, PHO has produced these best practice recommendations for antimicrobial resistant organism screening that includes those for Candida auris. So risk factor-based screening would include, has this patient or resident been admitted to a healthcare facility outside of Canada within the last 12 months? Have they been transferred from a Canadian healthcare facility with an ongoing outbreak or transmission of Candida auris? Does your patient have a prior history of colonization or infection with C. auris? And is the patient or resident flagged with a history of Candida auris or exposure to Candida auris? Sites for screening include bilateral axilla and groin, NAIRS, as well as any clinically relevant sites. So this is all available again on the PHO website in case you're interested in this. So I think the takeaways for today are Candida auris, and I didn't show a map globally, but it has increased rapidly across the globe since 2013. There has been explosive growth, not just within the United States. I'm just using that because they're our closest neighbor and they have an excellent dashboard. But other countries have also seen this explosive growth, thought to have really, in part, been driven by some of those pressures in the pandemic on healthcare systems, as well as probably a very high amount of colonization prior to the pandemic. Only a minority of these cases, these colonizations, will progress to invasive disease, but the mortality is high. Treating these patients is very difficult, and it's just a very large infection control challenge. I don't think I need to convince this audience of. So in terms of Canadian healthcare facilities, I think the numbers are low, but we need to remain vigilant to try to keep it that way. And I think that's one of the main drivers to making it a reportable disease. Let's try to understand our numbers. Let's try to understand the epidemiology, and let's try to make sure that we keep these numbers low, because you can't bring them back. Might bring them back down. So be familiar with your yeast identification SOPs. So how you're working up yeast, as well as the systems that you're using to identify them, as well as available screening methods that you have available to you, and the recommendations that are available. And be familiar with the diseases of public health significance requirements, as that is now legislated. Reach out to our lab if you need any isolates for validation or other support. And please continue to keep sending isolates from new cases to our lab to help support provincial and national surveillance efforts. And that's, oh, and thank you to everybody who helped make this possible, including all our mycology staff, PHO's wonderful IPAC and antimicrobial stewardship teams, the NML, Allison and the CNISP team, all our public health units, and TIBDN. Thank you.
Yeah, that may be true, but I'm still going to ask you a question. I'm really sorry. What's your take on sensitivity of PCR versus culture for the detection of colonization? Do you think we're going to be able to manage with culture alone if we want to control this?
It's a good question. We don't do that at PHO. We don't process screening specimens. So I'm sure many of you are aware that there are protocols that help kind of enhance or support the growth of Candida auris over other Candida and other pathogens prior to plating it onto a chromogenic or a selective agar. And that's wonderful. And I think that does enhance your sensitivity, but it also slows down your turnaround time by a day or two. So I think there's really a balance in terms of, there's a balance. If you want, you can do more testing with a shorter turnaround time, but you're going to lose some sensitivity, or you can gain sensitivity, but you're going to lose on turnaround time. So I think that's one of the reasons a lot of people are moving towards molecular, but I think molecular only makes sense probably financially if you have a high number of cases. So in our setting where we have not very many cases, it's pretty hard, I think, to make the economic decision to go to PCR and screen everybody when your percent positivity is going to be so low. So I don't have really an answer for you. It's going to be a balance between your needs as well as your local epidemic.
Okay. So now you get to pretend that my name is Conrad, and I know something about bioinformatics, both of which, of course, you know, are not true. So Conrad apologizes for not being able to be here. The good news is you are going to have to deal with him on two levels. First, because he's going to have to be presenting some of his Candida work on the either the November TIBDN days or next spring's TIBDN days. And secondly, because he's leaving us in July to join the Clin Micro program at the University of Manitoba. So he will be back in all of our lives as microbiology and ID folk in the future. So this What I'm going to present is the results of a project that was done by Conrad and Kajal Agarwal, who's a master's student who just finished her master's in TIBDN. And the goal of the exercise was to try to look at where CPE in long-term care homes came from as we first saw CPE emerging in Ontario. And the background to that is that in many American states now, long-term care homes and long-term care acute hospitals are major reservoirs of CPE, and that's also true in Spain and Italy and a bunch of other countries. In other places, Singapore, for instance, doesn't actually look as if there's much transmission in long-term care, and so Singapore is not worried about relative amplification in long-term care. And a piece of those differences might be because long-term care is different in different countries, right? We don't have long-term acute care hospitals in Ontario. Nobody in long-term care is on a vent, right? So the populations are significantly different and the care is significantly different. And it's not immediately obvious what's going to happen with transmission in hospitals versus long-term care homes. So we started this with the hypothesis that at the beginning of CPE emergence, what was going to happen was that most people would be acquiring CPE in acute care. But because people who go to long-term care are more frequently admitted than other people, and because they stay longer in hospital, that they would end up, most long-term care patients would have acquired their CPE in acute care and then taken it back to long-term care. We didn't know that, okay? So this is TIBDN data again, right? 4.7 million people, 28 acute care hospital sites, 120 long-term care homes with a little over 19,000 beds. And this is not a systematic in the sense that we go out and we screen everybody for colonization. This just captures the CPE that were reported in TIBDN surveillance. So from the beginning of time of CPE, that's 2007, until June the 30th of 2023, there's 1,576 total CPE, total people colonized infected with CPE in the population area. 55 of those cases, that's 3.5% of the total, are long-term care associated. And so you can immediately see first that there are relatively few of those patients are long-term care, but secondly, that the proportion of long-term care people who are CPE positive is much higher than the proportion in the general population. And here's incidence of CPE over time. This is clinical isolates of CPE, now, so not including people who are colonized. It looks, you'll see on the bottom as if there's not much increase in community-acquired cases. That's just because of the y-axis on this. When we get to TIBDN update, I'll show you what it actually looks like, which is not nearly so nice. But definitely much higher frequency of CPE in long-term care than in the general population. What people have with CPE in long-term care is also different. So you can see that compared to the general population, people in long-term care who are colonized and infected with CPE are more likely to have Club pneumo and Enterobacter, and more likely to have KPC and NDM. And that's probably a function of relative acquisition, right? They have a lot of people in Toronto and Peel who acquire their organisms in other countries and when they are hospitalized or in the community and the Indian subcontinent. So that's a lot of NDMs. But you would expect that people who live in long-term care have less exposure outside the country and more exposure to Canadian hospitals. And so they're more likely to have our hospital-centric organisms, which are Club pneumo, and Club pneumo is mostly KPC. We then went and asked where long-term care residents acquired their CPE, and I won't put up the long, painful algorithm about how we did that. We started thinking about, like, where do most people get their CPE? So most people in Toronto and Peel over this period of time acquired their CPE in a hospital outside of Canada or by travel to the Indian subcontinent. And so you can see On the left of this, there were, in fact, this is a percentage of people. So there were, I think it's 7 people who were long-term care residents, but acquired their CPE when they were hospitalized outside of the country. So generally people who needed acute hospitalization outside of the country and then came back and were transferred to long-term care when they returned. And then we worked through outside the country, hospitalization in Canada, exposure to another resident in a long-term care home with the same carbapenemase gene, and from EPI, from EPI alone, we could get about half of the long-term care residents that could be assigned a case. So those are people with hospitalization outside the country. These are people who have traveled outside of Canada. These are people who were the second person in a long-term care home to have the same species and gene as a previous person in a long-term care home. Those people we assume acquired it in long-term care. Then we had another 29 cases, about some of which we just didn't have data on, so we could not tell, but about half of them were admitted to acute care, not screened on admission because none of us were routinely screening long-term care residents being admitted to hospital for most of these years, and then positive later in care, so we couldn't tell whether they'd brought it from the long-term care home or whether they'd acquired it in the hospital. And for those cases, we added whole genome sequencing. So what we did was we went back and we looked at the hospital they were admitted to, and we asked about every CPE colonized or infected patient in that hospital in the previous year who had their CPE or likely had their CPE before the long-term care case and who might have transmitted it to the long-term care case. And then we did whole genome sequencing on those isolates to ask if we could identify that there was somebody in acute care who likely transmitted it to a patient with long-term care. And then we went back and checked the epi and said, okay, if we think there's transmission in this hospital, is it somebody who shared a room? Is it somebody who shared a ward? Do we have any epi links between the cases? So of those 16 cases where we didn't know whether they acquired it in long-term care or acute care, 9 of them were clonally related, so a SNV difference, if you're into SNV differences, of less than 20 between the acute care case that occurred before and the long-term care case. 4 of them were linked by highly related plasmids, right? With CPE, it's not just the clones that get transmitted, it's also plasmids that get transmitted from one organism to another. And when we went back and looked at the epi, 63% of the long-term care cases were linked by shared time in a room or in a unit. So the epi and the whole genome sequencing then largely matched with what we thought. The last question we asked was, okay, so a long-term care resident is colonized with CPE, do they expose their homes? Because if you get admitted from long-term care and you're into the hospital and you acquire CPE in the hospital, you're a long-term care resident. But if you don't go back to the long-term care home, who cares, right? Or if you don't go back to the long-term care home until we know you've cleared colonization, doesn't matter. So we looked systematically at who might have exposed their home, and about a little more than half of residents definitely exposed their home. So they were positive from a urine culture while they were actually living in the nursing home that was sent to Life Labs or Dynacare, or they were positive when they were admitted to the hospital, or when we did the assessment of exposure to cases and whole genome sequencing, they'd actually acquired it in a previous hospital admission, weren't detected until the next hospital admission, but had been in the long-term care home in between. And another 40% of people were people who were positive in the hospital and were discharged to long-term care, but they didn't have any screening between the time they were first identified as positive and the time they went back to long-term care. And anybody whose last positive was more than 3 days, we classified as possible because people do clear their CPE carriage. And the range, I think, of last positive before discharge to long-term care was 3 was the minimum, and I think 335 days was the maximum. So there's quite a lot of people who are several months out when they went back and might have cleared their CPE before they left. We recognize, however, that the data from Italy suggests that people who are old and frail and are discharged to long-term care seem to carry their CPE for longer periods of time than the general population. So what we've demonstrated through this is that long-term care residents are a small fraction of CPE, but incidence is consistently higher, so need to be worried about them. Over this period of time, the majority of acquisition actually occurred in acute care. So if we want to solve the problem of CPE transmission and not having increased CPE cases, we need to be focused on acute care. But it's also true that there was transmission in long-term care, so we need to be thinking about both long-term care and acute care in screening strategies. And then finally, one of the big questions on our list is, should we be screening people coming from long-term care homes into hospitals now? Is this something that we should be adding? And there are some hospitals in Toronto that are doing it and some hospitals that are not. We don't know what proportion of long-term care residents are positive when they're admitted to hospital directly. But you have to remember that for CPE screening, the positivity rate that's cost effective is less than 1%. Okay, so at 3 in 1,000 people positive on CPE screen, I know this sounds unlikely, but it's nonetheless, there's 3 cost effectiveness analyses that all say the same thing. You probably should be screening. And so I think one of the implications of this is we should all be thinking seriously about switching to screening residents coming from long-term care and also residents with a history of previous hospitalization now. That's obviously not a trivial thing to start doing, but we'll come back and look at what's happening with CPE and talk about whether we need to do it. Okay, so special thank you to Conrad and Kajal, who spent a lot of time working on this, but also to everybody who got phone calls from us, like Julianne. We've been calling everybody in the world saying, can you just tell me what room that patient was in, please? We thank you very much for that help. Comments or questions? Yeah, okay, so so we will come back to it. I think what we're seeing is, we know what kind of works. Okay, it's unidirectional and it moves fast. And despite a lot of effort, and I think a substantial amount of control of CPE material, CPE numbers are inexorably increasing. And this is AMR. Heard in the AMR story. We need to be figuring out what we can do about it, because for those organisms, healthcare institutions are clearly a problem. And healthcare institutions do wonderful things for a lot of patients. But we've got to stop gifting people CPE and Candida auris in healthcare institutions. And so somehow we need to figure out what it is that we do to do that. I do think, one of the really difficult things is that, with our infectious disease tabs on deal with individual patients, when you're dealing with screening programs, you're not going to detect everybody. Okay, the question is what percentages come up. Okay, and so that's the other thing that we have to be doing about, right? It's not can't have a single but it affects every person who's qualified, so and get it through the reasonable budget and cost effective. You have to figure out, what's the best you can do and try to understand what you're giving up and how you might detect the cases you're missing, if something goes wrong. So it's I think a complicated and difficult discussion. Okay, so we're technically late. Are people good to live for 10 more minutes? Just talk about hantavirus. So first of all, just a reminder about TIBDN surveillance, which is up here. This has not changed from the November slides. Candida auris and sterile site isolates of Candida are coming in 2026, but they're not here yet. And then let's talk. So I'm going to tell you what I know about hantavirus, and then everybody else can chime in on the things that they know that I don't know yet, because I know there's a whole lot of them. Okay, so this is the boat. Okay, it's a Dutch company, and this is a polar explorer ship. So what this boat does is it does tours in the summer in Antarctica, and then tours in the winter in Antarctica, and the summer in the Arctic. And the trip it's on, okay, is a trip that is going from the Argentina to Spitsbergen, which is where the summer tours start. So it's kind of an in-between trip for them. It's a relatively new boat, like built 2017, goes through ice and does wonderful things, so you can tour in polar areas. And if you're worried about rats on board, this is why it's important to be a birder, okay? Because rats and rodents are a really big deal on the southern islands in the Antarctic, because they eat birds' eggs and other things. So all of those islands are rodent-free. And you don't get to be a boat that goes near those islands unless you're rodent-free. Okay, so this is not rats on boats, despite what many people in the Twitter sphere seem to think. So currently, there's 146 people from 23 countries that are still on the ship, just to give you a sense of the breadth and the depth of how much trouble this is. But also that you can see they've been leaving people behind as they move north, because this is not the exciting cruise, right? The exciting cruise is Antarctica. This is just like sailing through the Atlantic, which you might wonder why people want to do. So then the quick thing on hantavirus is everybody's been talking about hantavirus as if it's one virus. It's not one virus. It's a whole group of viruses, and they're different in the Americas and in Europe and Asia. In Europe and Asia, they cause hemorrhagic fever. That's the HFRS, hemorrhagic fever with renal syndrome. And most of the American hantaviruses cause hantavirus pulmonary syndrome or hantavirus cardiopulmonary syndrome. And in almost all cases, it's a zoonotic infection. So it's not just rodents, but specific species of rodents for each hantavirus, okay? This does not include house mice, okay? Anybody's worried about mice and they're building their apartment or whatever in Toronto? Not a problem, okay? So it's specific rodents. And if you inhale, so if you go in and clean out a barn that's full of rodent shit, then you aerosolize the virus, you inhale the virus, and you get sick. But the Andes virus, which is limited to Chile and Argentina, is the one hantavirus for which there is demonstrated person-to-person transmission. That's been really difficult to sort out because there have been a bunch of systematic studies that try to look for seropositivity in healthcare workers or in household contacts. And in general, when you do those big systematic studies, you don't identify that there's a risk. But there's also one household contact study and 7 cluster investigations that have, at least in my view, demonstrated pretty convincingly that there is some level of person-to-person transmission. It's really hard to assess the household contacts because it's the same problem with the first 2 patients on the boat, right? They're traveling together. So yes, one might transmit to the other, but they've also been exposed to almost all the same things, right? So it's really hard to separate that out. And so when 2 people in a household get sick, distinguishing whether they got exposed to the same thing, especially since the incubation period of hantavirus is long, right? 14 days-ish, sometimes even longer, is really hard. But there are at least a couple of the outbreaks or situations where people were transferred from one smaller community to a tertiary care hospital in a bigger community. So it's hard to imagine that the healthcare workers who got exposed and got sick had a similar exposure to the person. So Andes virus is, and nobody knows why this is true. Okay, just is. And there's still, as you've seen, not a lot of data. So here's the boat. Okay, the MV Hondius left Argentina on April the 1st. The case 1 and his wife, case 2, had been traveling in Argentina before they got on the boat. I don't have any idea how many people were already on the boat from a previous Antarctic cruise or whether everybody got on the boat in Argentina. So I think it's still open question is about how many people, how many other people might have been exposed in Argentina versus on the boat. The first patient died on April the 11th, but their next landfall in a populated place was in St. Helena on April 24th. And when they got to St. Helena, some number of people, okay, I've seen 24, 29, 40. So there were a bunch of people routinely left the boat. Okay, so they ended their cruise in St. Helena and flew home. And case 2, who was the wife of case 1, flew with her husband's body to South Africa and then was going to fly on to the Netherlands, where she comes from. But she was too ill when she tried to get on the flight to the Netherlands and was refused boarding, and she died later that day in South Africa. On April 27th, the boat has made it as far as Ascension Island, and case 3 is evacuated from Ascension Island to South Africa, and case 3 is the case that somebody first thought of hantavirus for. Okay, brilliant move. You can imagine that we might be absolutely nowhere at this stage if somebody in South Africa hadn't been smart enough to do that test. A few days later, case 4 dies on the ship, and there's another, if I'm counting them right, there's another 4 cases on the ship. Case 5, who's a close contact of case 4, they sound like husband and wife, but can't tell for sure. Case 6 is another passenger, don't know anything about it. Case 7 is the ship's doctor. Okay, so now you see why people are really thinking this is person-to-person transmission, right? So this looks like 2 husband and wife pairs, certainly 1 husband and wife pair and 2 other co-travelers, because 4 and 5 are close contacts, and the ship's doctor. So both the timing of when people got infected and who's getting infected suggests that we're talking about person-to-person transmission, but also somewhat reassuringly, like really close contact person-to-person transmission, given there's a few others. So there's also, as of May 7th, there's 2 other new cases. One is one of the Swiss guys who left the boat from on St. Helena on the 24th of April as routinely leaving the ship. And the company sent everybody who had been on the ship notification that there was hantavirus, and so he told his doctors in Switzerland, and they tested him, and he's positive for hantavirus too. And just this morning, there's a stewardess who was on the KLM flight that the wife of the first case, when she was refused boarding because she was too sick. So that stewardess had contact with her in the process of them figuring out how sick she was and refusing her boarding. Now, that stewardess has respiratory symptoms. She's being tested for hantavirus. Who knows, right? But you can appreciate the complexity of this investigation, where there's people in 20, I think it's 26 different countries, and where you have 143 people who have been potentially exposed to a disease that has an incubation period that maxes out at 30 days, and whose only way of getting home is to fly. It's so what I heard this morning was that there's a military hospital in Madrid that they're evacuating them all to, and presumably they will wait out their 30 days, poor souls. Well, as somebody pointed out, these of course are rich people, okay, because it's not cheap to go on these cruises, but so they're rich, poor souls, in my view. But they're going to be stuck in a military hospital in Madrid for quite some time. Okay, so a few more things from TIBDN, just because I can't resist, and we missed them the last time. This is a paper that Jim Kellner and Leah Ricketson from Casper in Calgary, they are our twin network for pneumococcal surveillance, looking at the risk of recurrent invasive pneumococcal disease, just with an eye to thinking about whether we should be prioritizing vaccinating people who have one episode of invasive pneumococcal disease immediately. Most of those people do have other risk factors. So most of them, you can say, well, it would be okay. But it seems to us like it's a really easy thing to say, okay, this is an easily identifiable person. She's had invasive pneumococcal disease. Just get a dose of vaccine into her now, never mind anything else. And so you can see out here that we're talking about from year 5 to year 17, people who've had one episode of recurrent disease still have an incident rate ratio compared to the general population of 50. Okay, so these are definitely people that we want to have on the list. And here's your CPE infection slide that I couldn't figure out before. Okay, so we look at CPE, we look at clinical isolates, which are a mix of, as you just saw with the Candida auris, they're a mix of colonization and infection because not everybody who has a clinical isolate is infected. And then we also look at bacteremias because bacteremias are definitely an infection. This just shows you that they are rising pretty much in sync. And they are going in the direction that we all know antimicrobial resistance goes in, but that it is now our job to try to change. So this is an update that Angel and Max just presented at the AMI conference in Newfoundland, and on the bottom is their publication in AMI that is not yet indexed, but is available on the JAMI website if you want to look at the instance of infection. And one other thing about CPE infections, one of the things that's become evident, and there's 2 Ontario studies, but there's also a bunch of others, is that people who are identified as CPE colonized have a non-trivial risk of developing an infection in the short term. So this is Christina Blajakovic's and Nick Daneman's study looking at population-based surveillance, and you can see that in their study, 20% of people who were first identified as CPE colonized developed an infection with a mean of about 30 days. And there's one study so far that suggests that people's mortality associated with their CPE infection goes down if you know ahead of time that they're colonized with CPE so that you adjust your empiric therapy. So now CPE identification is not just about preventing ongoing transmission to other people. It's also about the possibility that you might then do better with empiric therapy if they do get an infection. And here's Angela and Max's data looking at the risk of infection, depending on whether you identify as having E. coli or Clebneumo or Enterobacter, and that the most important of those, as you might expect, because of hospital-acquired infections of Clebneumo, are Clebneumo, but again, very similar to Christina's study, that nearly 20% of people develop a clinical isolate, and it's in the short term. So it's not something you have to remember for a year. It's going to happen early on. That is it, and only 20 minutes late. I'm sorry. Very kind.